Bore da bawb a diolch am ymuno gyda ni heddiw ar gyfer cyfarfod rhythwyr Bwrdd Ymddiriedolaeth Prifysgol Velindre. Good morning and welcome all to Velindre University NHS Trust Board's virtual meeting held in public. Byddwch yn gallu arsylwi y cyfarfod heddiw, ond ni fydd cyfle i chi gyfrannu. Rydym yn recordio'r cyfarfod a bydd copi ohono ar gael ar ein gwefan yn fuan. You join us today as observers, which means you cannot participate in the discussion. A video of the meeting will be available on our website as soon as possible. Cadeirydd y cyfarfod heddiw yw Cadeirydd yr Ymddiriedolaeth, yr athro Donamid OBE. Mae 6 aelod annibynnol arall gan y bwrdd fel y gwelwch o'r wybodaeth ac gyflwynir. Today's meeting will be chaired by the Trust Chair, Professor Donamid OBE. As you can see from the slide, the board also includes 6 independent members. Yn ymuno â nhw, mae aelodau bwrdd gweithredol yr ymddiriedolaeth. Joining them today are the Trust's executive board members. Croeso hefyd I rai o'n partneriaid allanol. We also welcome some of our key external partners to today's meeting. Mae'r bwrdd yn gyfrifol am reoli perfformiad a strategaeth yr ymddiriedolaeth. The board is responsible for the strategy and performance of the trust. Bydd y cadeirydd yn agor ein cyfarfod yn awr. The chair will now open our meeting.
Bore da pawb. Welcome to Velindre University NHS Trust Public Board meeting for July 2021. And as you've just heard, we're pleased to confirm that this meeting is being live streamed today and will be available on the Trust website should members of the public and staff wish to view it at their convenience at a later date. So those of you who've joined the meeting today, croeso cynnes iawn I chi gyd, and I understand there's a mix of the public and our own staff. You're all very welcome. So I'd like to call a start to the meeting now. Throughout the meeting, we've got a number of matters for approval. Just to remind board members, if you wished, when I'm asking for approval, I will ask for colleagues to raise their hands to show their approval. And at the end of papers, I'll invite questions or observations. And if you could also raise your hand if you want to contribute to the meeting at that point. So to turn to 1.1 of the agenda, which is apologies. I have apologies from Mr. Carl James, our Director of Strategic Transformation Planning and Digital, and he'll be represented this morning by Mr. Stuart Morris, our Chief Digital Officer. I'm not aware of any other apologies, so colleagues, is anybody else aware of anybody who's not attending today? Thank you. So I'd like to welcome our regular attendees who are very much part of our Public Trust Board. Katrina February, Audit Lead Performance, Audit Wales. Stephen Allen, our Chief Officer for Cardiff Community Health Council, seems to inform me that he has to leave at 12:30 to attend a board meeting. David Cogan, our Patient Liaison Representative. I've seen David earlier. Good morning, David. And I understand that Kerry Harris, our Diversity and Equality Manager, is joining us for agenda item 7.5, and we'll welcome Kerry when she joins. Moving to 1.3 on the agenda, are there any declarations of interest which are pertinent to the items on today's agenda and which need to be declared? Can't see any hands up, so so that's a no. Thank you, colleagues. So we move to section 2 on the agenda, which is the consent part of the agenda. And there are a number of items in this section, as usual, for approval, noting, receipt, and so on. I want to ask if colleagues are content with the consent items, or if there are any items which need to be moved to the main agenda, and then we can decide where best to take that particular item. There's one item that because it's for approval, I would like to pull it out. It's item 2.16, Appendix A under that item. I discussed it earlier with Lauren. As we're asked to approve that particular item, I think we should note what we've now concluded is possibly an error from Welsh Government. So we would only be able to approve that item subject to confirmation or correction of that error, Lauren. Shall I explain which item it is? You may as well. It's
yeah. Or I can.
It's under the Trust Board's revised model standing orders and standing financial instructions, the cover paper. I'm referring to Appendix A in that paper, which is a table which I've been informed by our board secretary has been provided for us by Welsh Government. And if you look at number 19 on that table, which I think is on page 5, and it's item 1.31. I can find it. Right. Can't find it now. Looked at this a dozen times this morning already. It refers to the tenure of independent members. And it says, under 1.31, tenure of board members, limitation of 8 years does not apply under the NHS Membership and Procedure Regulations 1990, therefore no limitation for Velindre and WAST. And Lauren, you've said you believe that to be an error.
Yeah, that is absolutely not correct. So we'll pick that up with government.
So will we approve it conditional on clarification, or will it bring it back next month, next board?
I think we just approve it on. I mean, we wouldn't include that in our. The table will now be translated into our standing orders, as the kind of paper explained. So we wouldn't transpose that across because it's not correct, and we'll pick that up with government.
We're asked to approve it today. So what I'm asking for advice from you, Lauren, is can we approve it today? We can't approve it. We can only approve it on condition, and the understanding that will be that Welsh Government will change that, or we have to bring it back to another board meeting when it's been altered. Which do you advise?
So I think we just approve it, knowing that the limitation is 8 years. And that won't be changed in the stand. That's what it says in standing orders now, and that won't be amended.
Okay. Thank you. I'm not sure I understand. Sorry, Laura, I'm not sure I understand that. Is this?
I don't think we need to bring it back. Basically, I think it's very straightforward. I think that we know what the answer is in terms of the limitation. That won't be changed in the standing orders. So as long as that's noted in the minutes that the table is incorrect, then we can approve it.
Okay. I think I just understood what you meant. But Steve, you had your hand up.
Well, that's fine. I think I was just going to say what Lauren has just said. So.
Okay. So thank you for that clarification. I want a medal for spotting it.
Well done. It's gone to every organisation, so we'll make sure WAST. I don't know if it's gone through their board or not yet, but we'll make sure. Thanks,
it's Lauren, thank you. So I don't have anything else that I would want to draw to your attention under the consent section of the agenda. No, so so we are approving those items which are for approval, and we're noting those items which are for noting. I can't see any hands up, so that takes us to section 3 on the agenda, which is the action log. And colleagues, you'll notice that all items on our action log from the Trust Board meeting on the 8th of June have been completed, which I'm very pleased to note that, because in the past things have remained open for a little bit longer than this, so that's very good to see. A wall of green there with all items completed. Does anybody want to raise any issues in relation to the action log? No, and then finally, are there any matters arising which were on the minutes, which are not captured in the action log, which colleagues want to raise at this point? And so I can't see any hands up, so thank you, colleagues, for that. We now move to we do have a presentation, but it's later on in the agenda in relation to our equality, diversity and inclusion section, but we don't. So we'll have that later on. So I'm going to take us to section 5 on the agenda, and it begins with the chair's update. So that's my paper. So what I would want to draw to your attention is item 2.12, where I note that at our last board development session, we were discussed and we went through the process of the judicial review, which has been launched by a member of the public against the Welsh Government for the approval of our outline business case for the new Velindre Cancer Centre. And there's an update on that, or there's a bit more clarification on that in the Chief Executive's report, which we'll come to next. I'm just noting with pleasure how the award of the George Cross Medal to the NHS for its service over the last 73 years, and also in relation to the pandemic. I'll take any questions on what's listed there, but I would just want to add to my chair's report that we held our AGM yesterday afternoon, and a recording of that will be available on the website soon. I'm not sure how quickly, but in the next days that will be on the website. And I also wanted to mention that the CEO and I had an introductory meeting with the Health Minister, Eluned Morgan, earlier this week, and the Health Minister was very keen to express her thanks for all the hard work during the pandemic, altogether, but in particular during the pandemic, and she wanted her thanks to be passed on. She has written to all members of the Trust to say thank you. We discussed a number of items, but it was very much in the vein of it was the Minister kind of getting to know us and our organisations as she settles in to her new role. And I'll take any questions on, if there are any, on any of the items I've listed in the Chair's report. And if not, I'll take us to 5.20, which is the update from the Chief Executive, Steve.
For Bob, just a couple of things from the report for me, just to say that there's no further update from the content of the report around the judicial review since the report was written. And I would like to note, I recall my thanks to Sue and Barbara as well for their chair and vice chair of the patient liaison group over the years. Thoroughly enjoyed working with the two of them, and I know they're still involved. I'm ready to thank David and Sian for stepping forward. I know David's the regular attendant to this meeting, and certainly I've met David many times over the years. I'm really looking forward to working with you and Sian as well, David. So thank you for that. One thing that's not in the report is an update on COVID-19. I want to keep that as current as I could, really. So just a quick update. In terms of COVID, you'll have seen the press about the numbers have peaked, seem to have peaked, and are starting to go down in terms of cases per 100,000, whilst hospitalisation rates are still relatively low. But you'll have also seen the pressure the service as a whole is under in terms of responding to particularly emergency and in terms of recovering from the pandemic, the acute phase of the pandemic. So I think the service is really under pressure. Demand's increasing fast, in particular, as we recognised it would start to, both in the blood service and in the cancer centre, with demand presenting at levels seen pre-pandemic and in some cases higher as well. And at the same time, still dealing with social distancing and IPC issues. And also, as people will be aware, staff isolation issues, which has been widely publicly discussed as well. And before I ask Sarah to come in about these staff isolation numbers, which she just give a quick update on, just to say in terms of our plan, we're well into recruiting for the new staff against our plan. The new blood team should be operational in September, collection team, and certainly the SACT and radiotherapy staffing should be online in September as well. Some of the others have a longer lead-in time than that. But Sarah, do you want to give a quick update on where we are in terms of isolation?
Absolutely, thank you, Steve. Just aware that the board will be very interested, obviously, in terms of how many staff we have currently self-isolating. As of Tuesday this week, 15 members of staff across the organisation are on COVID special leave, which implies self-isolation, and also getting reports from the two operational divisions that we're keeping a very close eye on people who have been contacted by test and trace, so pinged, as the vernacular says. So we've not currently got groups of staff from one area, so it's not causing significant difficulty in terms of operational delivery. But we have had, even in the last week, a group of 4 staff from one quite relatively small team who were all contacted at the same time. They returned to work within 3 days following negative tests. We're keeping a very close eye to see if that changes. Also, just to make the board aware that there is work happening nationally in the development of an approach we can take to mitigate any potential operational impact of large numbers of staff being contacted by test and trace. And so we're expecting some guidelines to come out in the next couple of days, really, to give us some options around exceptional circumstances where staff may be absent as a result of that. So we need to keep keeping a close eye on that, and we're obviously involved in the development of that guidelines. Thank you.
Thank you, Sarah. I'm happy to take any questions.
Oh, Martin.
Thank you, Steve. In your report, there's a section about the Green Health Wales launch, and I'm very interested and excited about sort of seeing that, because obviously, as you said, the climate emergency, as you say here, is also a health emergency. In there, you've suggested a number of steps to take to decarbonise our estate and recognising the hugely electricity intensive nature of some of our stuff. So our very big, expensive bits of kit are obviously drawing lots of electricity. I'm just kind of wondering more generally about infrastructure, solar panels, electric fleet, all those things don't come cheap. And I wondered, with the Green Health Wales initiative, whether any money came attached to that, or is that going to be funded out of our existing budgets?
No, Green Health Wales was very much an organic staff-led initiative, which Andrew Goodall spoke at the beginning of the session. So I think it's that organic, it's getting that momentum going amongst the 90 to 100,000 staff. And it was driven particularly around some initiatives that were highlighted around ICU, where people were striving to actually make that far more carbon neutral than previously. I think that energy, I think, is going to be crucial for us, because it's not about some of us in the board deciding we're going to be carbon neutral or green. We need everybody doing that in the same way as we need everybody in society, don't we, to move. So I think it's a really important and exciting step forward, and it will mobilize and galvanize people. And there were some really exciting presentations, actually, really interesting things going on.
That's really healthy, and to see it embedded in the organisation is really positive as well. I wonder perhaps some sort of board briefing might come on the work that we're doing.
Yeah, I'm not sure if it's in the programme yet, but I certainly think we should. I think we need to take stock of what we are doing.
Yeah.
And then think about what we're not doing, Martin, and where we go next with it.
Thank you.
There's a lot going on it, but I think making it visible and determining where we go next as an organisation will be really important.
Thank you, Martin. There was a white hand up above your head, Lisa. You're not. You didn't have your hand up, did you? Okay, just a glitch then, I guess. So thank you for that, Steve. So we come to section 6 on the agenda, which is quality, safety and performance. And the first item in that section is the highlight report from the meeting on the 15th of July. Colleagues, there are a number of typos in this report, which I'll send to you, Nicola, later on, so they can be corrected. So apologies for the typos, but I'll hand over to Jan to present the report.
Thank you, Chair. This was our 5th meeting. We meet bi-monthly. Our 5th meeting under the new structure. It's a packed agenda. There, as you can see, there were no items on to alert the board. There are 8 items within the advice section that we wish to provide the board with assurance of. The first 3 are highlight reports. And then we actually started the meeting with a donor story of a blood donor who contacted the service having been distressed by the introductory paperwork following a tragic miscarriage. I think it's a really useful example of agile working in the way that the blood service worked with the distressed donor to co-produce a solution so that other people wouldn't be put into this position, and a very positive, fast turnaround. I'd like to commend the Welsh Blood Service for that piece of work, but also in the previous highlight report, you can see that there are safeguarding issues which also were addressed in an agile manner, where children being brought into blood donations, which has always been an issue, but obviously in these days is considerably much harder to manage. That takes us on then to the NHS Shared Services Partnership Quality and Safety Committee minutes. For us as a Quality and Safety Subcommittee of the board, we have to have a clear line of sight, and we felt that we needed more information. So we're going to review their standard operating procedure and have sight of that and have a look at that. And also they're going to report on a regular basis to future quality and safety partnership meetings to make sure that the strand of governance gives us that line of sight. The next item was the financial report in June, which is on today's agenda. And then we looked at the Putting Things Right annual report. And finally, within this section, an update on the risk register work that's been ongoing and a review of the open risks on Datex version 12. Within the advice section, there are 8 items, and I won't draw your attention to any of them specifically. But I'd also like to note in the informed section that Audit Wells is undertaking a governance review in this area, and I actually had I think I was the first person to be interviewed yesterday, so they're trying to get me before I leave, but I think it's due to really gain pace in the autumn. And finally, a further presentation, other than the donor story, was on the Our People's Charter and the implementation of that. We will be, the Quality and Safety and Performance Committee will be focusing on that going forward. Happy to take any questions.
Thank you, Jan. I think, colleagues, when you read through this report, you get a feel for how huge the agenda is for quality, safety and performance. And as you say, Jan, we've had 5 meetings under the new arrangements, and this will come under review in the autumn when we take a look at our new committee structure and how it's been working. But I'm very grateful to you, Jan, because it's a huge agenda to chair us through that meeting. And I would like just to echo your comments about the agile way in which the Welsh Blood Service responded to a potential donor concern. The lady concerned had been pregnant, and the screening questionnaire at that time asked if you'd been pregnant in the last 6 months, because there's a time lapse then during which you wouldn't be allowed to make a donation. But then the screening tool went on to presume that you'd had a live baby. And of course, this particular individual hadn't had a live baby because she had quite a late miscarriage. So to see images of dummies and various things was so terribly upsetting to that lady. But within days, the Welsh Blood Service were working with this lady to put that right, so that the screening tool was fit for purpose for individuals for whom a live birth wasn't the outcome of the pregnancy. And the lady concerned made a video cast, Jan, didn't she, for us, and talked through her experience of working with Welsh Blood to put this right. And I don't know if that's available. That could be made available for all board members, IMs in particular, to watch. But it really is an example, I think, of excellent practice in terms of, you told us something and we moved very quickly and put it right.
I also think, Donna, it's a real example, because we know of the high rates of miscarriage, and that this won't have been the first time that has happened to somebody, and how hard it is. What it demonstrates to us is that with such yet a common experience, people still don't feel okay about coming forward. She was a remarkable individual, and
yeah,
thank you for coming forward. But I do think it shows how hard it is to come forward and to say to an organisation on such a common experience.
I couldn't agree more, Jan. I couldn't agree more. And just moving on for a moment, pointing out the number of estates issues that we looked at during that meeting as well. It really is an enormous agenda, but it does give us, Jan, as you've noticed so many times in the meeting, the opportunity to bring things together, to look at what estates are doing in relation to what finance is doing, and other performance issues. So it's not a downside, but we've got to cope with a large agenda. The benefit is that we can pull these things together.
Well, it was our intention to triangulate as much as we could do.
Yeah.
Because, the NHS, like all organisations, produces a huge amount of data. And on its own, it doesn't really tell a story. It's only when it's put together in that jigsaw. And I can really feel after 5 meetings, that jigsaw beginning to, we're getting a picture now in a way that we didn't before. So I'd like to thank the work of Lauren and Nick for getting us to this position. Thank you.
Thanks, Jan. Nick, I can see your hand up.
You and thank you, Jan, for your tremendous chairing of that committee and bearing with us while we've been working through it. And just continuing on that discussion, really, I think workforce for us was a real triangulated theme that emerged from a number of the papers at the last meeting and presentations, and it did allow us to look at all areas of workforce, including performance, training, PDR compliance, but also well-being and support for our workforce. So it really does help us to bring everything together. I mean, we have, we do need to refine what we are doing, and that work has already commenced. So just to give the board assurance that we have already met and meeting with executive colleagues over the next few weeks to further refine that and look at how we can better triangulate and optimise the reports that we are providing, particularly across functions.
Thank you, Nicola. I can't see any other hands up, so I just wanted to highlight, colleagues, that that was the last meeting of the Quality, Safety and Performance Committee that Jan will chair, because she's on leave in September when the next meeting happens. And she leaves us at the end of September. So, Jan, can I, at this board meeting, record formally, our immense thanks to you for the last 9 years, in which you, as an independent member, have championed the trust and provided scrutiny and challenge, and brought your particular skills and expertise particularly in relation to the area of safeguarding, to bear on the work of this committee and the trust. We can't ever thank you enough, Jan, and whatever you will be doing in the future, we wish you all the very best for that. And Jan, I know you and I've had a discussion, and you are preparing a legacy statement for me, which will be available to hand over to whoever sits in your chair next. And it will, that legacy statement will be very helpful to us, Lauren, as we move forward with our evaluation of how the committee structure has worked for us over the last year.
Yeah.
So no, this white hand keeps appearing on my screen. It's above Martin Veal at the moment. Martin, your hand's not up, is it? Right, if I see this white hand anymore, I'm going to ignore it. So the next item, so we note that the contents of the highlight report, and thanks to Jan. Next item is 6.2, which is the Remuneration Committee highlight report. And you will have an opportunity to read that, and there aren't any issues I wish to draw to the board's attention, but I'll take any questions. Thank you. If there aren't any, then we come to 6.3, which is the Local Partnership Forum highlight report, which Sarah is led by yourself, so I'll hand over to you.
Thank you, Chair. So this is the Local Partnership Forum highlight report of the meeting held on the 6th of June. And you can see there's nothing there to alert or escalate. So it was a meeting where we approved the Local Partnership Forum annual report. We also noted the respect and resolution policy, which had previously been signed off by the Trust. We then talked about obviously other areas of work we're involved in, such as the third-party contract involvement moving forward. And we were discussing how the trade union representatives could best be represented on the Agile Working Task and Finish Group, which is a piece of work we've currently got ongoing, and also the Infection Prevention and Control Management Board, as you can see. Other aspects of work there, you can see we also have the presentation at this meeting that Jan was describing that went to QSP committee on the health and wellbeing work, because we're very keen to engage all relevant partners in that work. And also discussed at this meeting how we are moving forward with building our partnership working arrangements, and that's ongoing, an ongoing conversation that we're having with trade union colleagues. Happy to take any questions on that.
Any questions or observations for Sarah? Thank you, Sarah. So we note that report. Now, what I've got in my agenda, and it'll be in yours as well, is a break, but we're ahead of time. So I'm going to suggest that, particularly as Steve Ham, I didn't mention at the outset, Steve has to have a meeting with Welsh Government at 12:30, and I'm not sure we will have got to by then, but I'm going to suggest we do at least one other agenda item before we have a break. That's okay. So this takes us to 6.5, delivering excellence performance report for the period May 21. Kath, we didn't expect that you would be here with us today. We're very pleased that you're with us today, but we thought you might not have been here. Are you going to present this report, or your colleagues?
Sorry, Chair, I'm having real computer difficulties today. Can you repeat that?
Oh, right. I said initially we weren't sure that you would be with us today.
Yeah.
You know, because you've been away a little bit just recently, yes, so we didn't think you'd be with us. So I'm not sure whether you're presenting. We're very pleased that you're here, but I'm not sure whether you're presenting this item or whether your colleagues Lisa and Peter are going to present it.
Okay, so we're going to do a bit of a treble act. So I'm going to let Lisa and Peter lead, and I'm going to pick up anything if there's any questions.
Okay, thank you very much, Lisa. So I'll hand over to you first.
Thank you, Donna. Thanks, Kath. So as you said, it's the performance report for May. This is our second one in the revised format that we've presented to the board, and continuing to receive very positive feedback on the new format, the further analysis and information provided. We've made some further additions following the April report, following feedback from executive colleagues, and that is primarily around providing more detail in the trend slide for inpatient services. We'll also continue to dual report now against the cost waiting times, but still awaiting the Welsh Government position on formal reporting. For the cost radiotherapy waiting time. So we're waiting for formal reporting requirements. The cost targets are showing as red and amber, whilst the Royal College targets that we are still using as the predominant measure are near compliance levels around in the high 90s. There is an implementation plan that's been received by the senior leadership team to improve compliance against the cost targets. And we are working very closely with colleagues in Swansea Bay in order to learn from their experience, ensuring that we're sharing good practice between both cancer centres. Pleased to say that the SACT targets have been met, but you will see from the narrative that the numbers coming through are significantly higher. And as Steve has said, we're already well underway in recruitment for the surge capacity that obviously is going to continue to come forward over the next months. The outpatient waiting time is the next one I would like to mention, and we're 79% against the 30-minute target, which is improving. I'd like to reassure the board that the long wait that is mentioned at 180 minutes was due to complexity of the patient needing to see a number of professions at their appointment, and we do look into each of these individually to ensure that we're learning from what happened to that patient, because that is an excessive wait. I know we would all want it to be better than that. There's a number of additional documents attached to the performance report that I believe were requested previously around some of the outpatients work. I wasn't going to go into those in any great detail unless there's anything else that you wanted from me, Donna and others.
Thank you, Lisa. I've just been informed by Emma what the white hand is, the mysterious white hand. It's wherever my mouse has landed, a white hand appears. So apologies for that, but I didn't know about that, so it's got me a bit confused. Thank you, Lisa, very much. I'm just wondering if everybody's up to speed and whether I could look to you, Jazz, for this. Lisa mentions COSC several times, which is the Clinical Oncology Subcommittee stretch targets, which is something fairly new in terms of our reporting. And could you just explain, how that is featuring in our performance review against the national targets that we've been used to seeing? Is that okay?
Yes, so I'll say what I can, and others may want to come in. Kath may want to come in as well, but I think that we have been on a journey with this. COSC is setting a national standard, and it's more about how we collect the information to be able to present the data, which is our problem, and less about the fact that we're not meeting the standard. So it's partly about where we start the clock in our request for an IRMA, which is the electronic radiotherapy request form, and what COSC is asking us to do in terms of the intent, the point at which we decide to prescribe radiotherapy. And because effectively our system needs to be able to pick up this information in the right way in order to present it. And because we're not able to do that, our figures are looking, there is a significant discrepancy in some of the measures being displayed here, which is alarming. And I think what we probably need to show you is the detail underneath it, which explains why they are alarming. And we're not necessarily demonstrating that in this way. So it is. We have flagged the fact that we collect the information in a slightly different way. Welsh Government are aware of that, but we are being tasked to address that and ensure that we can be consistent in the way we present it. So that and perhaps Kath might talk about how we're intending to do that.
That's a very helpful explanation, Jazz, and I'm not sure that everybody, including myself, was up to speed with that, but I think it ought to eventually resolve a long-term issue, which Kath and I have discussed many times, in which it looks as though there were breaches of the target, and in fact that wasn't necessarily the case. So and there wasn't any way to record or demonstrate that. Have I got that right, Kath?
Yeah, well, I think there's a number of factors at play here. And first of all, my apologies. I've lost the track of the conversation, having been off for a while, and I should have recognised that this is the first meeting of the board at which we've started to have these figures flowing through. The board may recall that in one of our development sessions a couple of months ago, we had a presentation that explained to us that the new cost targets were going to change the definition of some patient treatment pathways. But before I touch upon that, I think I just we are at a public meeting, and it's important for us to record the fact that different patients will have different pathways depending on their condition and their need. But what we try and do is we set targets for the times within which we think that should happen, and we set that as an overall rather than for individual patients on different pathways dependent on the site of their condition. And we know that there is some variation in that. So what these figures do is they make some changes to the definition of different patient groups over and above the figures that we were previously using. And what they also do is they require us to capture different pieces of information at different times. So there are some anomalies in terms of what we're reporting, but the overall aim of these is to really make us focus on where we can put improvements into the system to make sure that each patient's treatment experience is as streamlined, efficient, and timely as possible. So they are setting us a stretch target. Because of the changes in the way that we're counting things and the different sections that different figures go into, it does create anomalies in the reporting. But what this does now is, and has already done, is to create a new focus for us on the information that we collect. But actually the important thing that's underneath that, which is what is the patient experience, what is the time within which patients are accessing treatment. So it's bringing our endeavours in applying these new targets are really just creating a new focus for us on different elements of the pathway and how we solve some of the bottlenecks in the system, as well as the underpinning system within which we're collecting the data, because the data is only important if it's actually linked to real patient experience.
Gareth, thank you, Kath. Gaz, you're on mute.
Yeah, thank you. Thank you, Jazz and Kath, for that helpful explanation. And I just wanted to check then, I'm looking at the cover paper in paragraph 2.4.1 around quality incidents not closed there. And that appears to have deteriorated since the previous month. So is that down to the difference in reporting approaches, or is there another underlying reason for that?
Sorry, Peter's got his Peter's raised his hand up on that. I don't know whether or not that was to come in and respond to this rather than me. But
just to give a little context around that, we had two factors that came into play there. So first of all, over the reporting period, there was a decrease in the total number of incidents reported. And that was also set off against a slight increase in the number of incidents that went over the 30 days limit. So both of those together would have affected the percentages. I suppose, whether we should take assurance or just keep close monitoring on the numbers of incidents being reported. I'm in the place that we should keep a very, very close monitor to make sure that everything is being reported. At present, we believe that we're getting probably a slight increase in reporting since we made the changes to DATIX in the middle of May. But we're also seeing a much faster turnaround of incident investigations and closures. So yes, that is a trend that we need to keep very, very close to. It's something that we have struggled with for a consistent period of time. But we do believe now that we can see a path forward that is giving us the right level of confidence, because we've got awareness of the need to report. We've got a very, very healthy and positive reporting culture at Welsh Blood and have done for some time. But we've now coupled it with a process which works quicker, works more smoothly, and it means people focus their attention on the investigation and the corrective actions that inevitably should arise from any investigation or from any incident being reported. But what you saw there was a crossover of a drop in the number of incidents reported, and some particularly tricky ones that just took longer than we would have liked to get to the bottom of.
Thanks, Peter. I can see Steve
Hand's
got his hand up.
Kath might want to say the same to me. So it was a really good response from Peter, but we're talking about two totally different things, Gareth.
Yeah, I think so. Yeah, from Gareth's question.
They're not directly related, but both are issues.
Yeah, so the cost issue doesn't come into the reporting of the length of time it takes to resolve concerns and complaints. I think that's what we're saying, isn't it?
Yeah. So the only changes that we have to target are the changes to the timescales and the categories of reporting our radiotherapy treatment targets, whereas the incidents relate to the rate of incidents that are being closed out within WBS, which is just the general incidents in terms of the operation of the business.
Okay. Thank you. So I've got a couple of queries, but I can see Stephen's hand is up, so I'm going to go to Stephen next.
Thank you, Chair. I just wanted to come back to wait times in outpatients, which I like to visit from time to time. I mean, in terms of the topic and occasionally
You mean every meeting, Stephen?
Yes, indeed. So I know we've done a huge amount of work on that, and clearly we're living in very different times from when we were discussing this 18 months ago. I just want to quickly just reflect on the situation outpatients now find themselves in when they attend, for example, our outpatient department, recognising, of course, many of them, from a positive aspect, get telephone calls or video calls, saves them a lot of travelling, but many of our patients still have to come in, and we've seen the distribution of weights, and we're not at the target yet. And I appreciate all the work that's going on, but the situation we find ourselves in is that for most of our patients going into outpatients, they have to go in alone. They can't take a family member or a carer in with them other than exceptional circumstances. And inside the department, quite rightly, there's a lot of social distancing. People can't sit anywhere close to each other. So I think our patients find themselves sometimes in a position, they're sitting in a big lonely department for a very long period of time. I know for many of them, it's a big, scary, frightening place. So I'd just like to get some sort of feel for what sort of things we're doing to look after our patients in that circumstance. The cafe's not even open, for example, go and get a cup of tea, they start getting thirsty. So we have touched on this before, and clearly we're there to give them excellent clinical care. And I know we all understand we're there to look after them in the round. So again, just during these long waits, particularly if we got frail, vulnerable, worried patients, what are we doing to look after them during these long wait periods?
Peter, there is a paper on triage and unwell patients, which is in the appendices. I mean, your point,
yeah,
your point's very well made.
I suppose just in terms of assuring the board, sort of the rather than the formal process, is what are we doing around perhaps just caring for our patients during these times in the outpatient itself, recognising they can't socially interact, they can't go and get a cup of tea, etc. I presume we're keeping an eye on them and looking out for signs of concern or anxiety, or even if patients become a little bit unwell. I'd say I don't know whether people just wanted to comment on that.
So I can see lots of hands up, and I'm just I got something I wanted to ask around this area, but let's before I ask that question, Lisa has a hand up, and then Jazz put her hand up. Anybody else? So Lisa, you were first. So I'll go to you first.
Yeah, just in response, really, that we are offering drinks as a matter of routine, even though the cafe's not open. Obviously, it's not just families that can't come in. We don't have the volunteers on site either at the moment because of the risks around that, and they provided fantastic support in that sort of pastoral way to our patients as well. So we are allowing families in if there is a reason, and we are working really hard on virtual technology so the family can join in from the outside as well if they can't be with them. So we are providing drinks. The nurse in charge will always be, as she has always been pre-COVID, within the department, and the triage staff have been fantastic in highlighting to the qualified staff when somebody isn't themselves or isn't well, and obviously they have the observations and everything checked, and if somebody isn't well, then that action would be taken appropriately. But it is on top of the forefront of the staff's mind, really, about not having the loved one there and the impact that would have.
Thank you, Lisa. Jazz? And then I can see Stephen's got his hand up. I've got Stephen Allen. I'll come back to Stephen in a minute.
Thank you, Chair, and thank you to Stephen for raising this. And it's an area that we mustn't lose sight of. So it's important that we address. I think that, I mean, I'm just looking at the statistics for the performance. I think the overall message is that is improving in terms of time, times of waiting times for patients. We are improving month on month in terms of how long people are waiting, and that's a positive thing. I think that I was in clinic yesterday, and I'm there probably twice a week, so it's not every day, and I can't tell you about exactly what's happening, but there is much more coordination and organization of the movement of patients in and out. And some of this, and a lot of this is the hard work of the nurses who are trying to run the clinics, and they will do everything they can in their power to minimize the time that patients are, the footfall on site. This does mean that some patients prefer to wait in their cars, so we're contacting them by phone to say, right, we're ready for you, and it's Jazz, are you ready for the patient now? Not making them hang around, bringing them in. You're right, Stephen, about relatives. I mean, we do, in certain cases, difficult conversations, we try to make those exceptions. But when you walk in, it does feel quite sparse, because as you say, people are sitting on a single chair at a distance from each other. But there are staff around, so I think it's about how we interact with them and checking on people who are actually physically present. But the overall sort of, I suppose, the environment is less intense. You don't get people queuing. We have got rid of some of those, I suppose, areas of concern or risk, but there is still and always will be more work to do. I think it's about how this changes. I think that the reality is, clinically, there may be more requirement for patients to be reviewed face-to-face, although we've still got this 50-50 split with what we're doing virtually. It's a case of how we can maintain that moving forward. Using our capacity in the outreach setting is absolutely key. There's several things that we're trying to do to ensure that is opened up. And we don't, put the pressure on the cancer centre to try and pick up this activity in its entirety. So I hope some of those are words of assuring you, but equally to say that it's absolutely top of our agenda to continue to work on.
Thank you, Jazz. Stephen Allen, because we've so many Stephens in this meeting, I've got to use their second names.
That's all right, no problem at all, Chair. Just wanted to say, actually, taking about what you were saying, and I appreciate the patients which coming into an outpatient clinic are unwell or going through treatments, etc. So putting that with a caveat to that is obviously what we're picking up from the wider community is actually that when you go to a restaurant with people, you can go to have your hair done, you can go and do all these things within society, but actually the NHS seems to be a bit slow in sort of reopening things back up and sort of taking that forward. I appreciate this going to be done in a cautious way, and nobody's saying anything more than that. I think that's where possibly the sort of where there's a sort of a tipping point really as to where you're going with this, especially as restrictions are being eased now across Wales on the 7th of August. We understand how are you going to adapt your operating procedures within outpatients to take account of that. Also, the fact of is that patients do talk to each other and families talk to each other. And therefore, if you're being asked to go in with your family, does that mean you're going to have bad news, or does that mean you can have good news? So it's a very fine balance to do that. And I appreciate you also doing some virtual discussions as well with sort of people within outpatients. Maybe outpatients needs to be sort of revamped totally to include that blended approach to virtual and physical appointments. But people waiting for a long period of time, isolated. Obviously, I appreciate you're putting some other bits and pieces sort of around that with drinks, etc., and sort of well-being. But it's all linked to something. So you said earlier on, I think Nikki mentioned about patient experience being really key. This is all part of their experience whilst they're waiting. I think maybe sort of volunteers in other NHS establishments are now back at doing what they do best, which is helping and supporting patients. Maybe you need to consider bringing your volunteers back online now to actually appropriately protected, of course, to make sure that those individuals have got somebody they can chat to, perhaps, or that type of thing. I think there's probably some further work to be done there to help that patient who is sat in that waiting area for a period of time of over 30 minutes, which is quite a long time to be sat on your own with nobody to talk to. So I just want to bring that to the table, really, and we'd be interested to know how you're going to change your approach as and when restrictions are eased to the level that we appear that they're going to be going from the 7th of August.
Thank you, Stephen. I can see your hands up, Kath. I just want to come in for a second and say, I'm very pleased to hear about all the measures that we're taking to make that experience as good as it can be under the circumstances, if I can put it like that. But I think the focus, what I need to hear is what are we going to do? And I think this is where Stephen and I've come from for a long time, is we need, the main focus needs to be to reduce the level of time that patients have to wait. And the other arrangements that we're making around drinks and checking on people's conditions and so on, which is excellent, but the main focus should be not having patients wait so long. So I leave that with the exec team to contemplate. And I know this is a piece of work which was well underway, and then COVID hit and upended everything, and we were thinking of digital solutions and so on. But I think what we need to be thinking about is reducing the time patients wait. Kathy was going to come in. I've still got a couple of points I want to raise, but we need to close this item soon.
So just very quickly, to provide you an assurance, as you mentioned, Chair, pre-COVID, we already had a work programme that was addressing a number of the operational challenges that we were experiencing in outpatients and making some really good progress. I think some of our solutions have been expedited by COVID and our ways of working. What it's also done is add another whole load into the mix that we're having to manage that we didn't have before. But rest assured, there is a programme. In fact, Lisa holds overall management responsibility for it within the Cancer Centre, that is looking at how we take a systematic approach to revising all of our systems and processes in outpatients. And there are additional opportunities there that are coming from the CANISC replacement as well. So all of that work is underway, and I think a lot of the points that have been made today are really pertinent to that, and hopefully, we are already taking them on board. So just to let you know that is all happening under the Velindre Futures programme with the development and delivery group in outpatients, and we'll be able to provide you with more of an update on that as we go forward over the forthcoming months.
That would bring me, Kath, to another point that I wanted to raise in general, and we've got the graph, the table now, the dashboard table, which sets out the targets and our performance against it. And it's very helpful to see it in this way. What we're not seeing now is the risk assessment, unless I've missed it somewhere, the risk assessment. So for example, where we've got breaches for radiotherapy, and some of those are really way below target, 35% and 28% in the last couple of months. In the previous way of reporting, you would demonstrate to us that how long was the breach, was the person clinically assessed for that breach, etc., etc. So we haven't got that information here now, and I'm saying that this would be the same with the outpatients. So you've given us a lot of assurance, and now in what you've just told us about the outpatient weight, but we've had to ask for it. Whereas previously, in the previous way of reporting, there was some information around weather areas of concern. There was some information that would give us as board members some assurance. So I don't know if it's possible to look at that, because the dashboard has solved one problem, but for me, it's introduced another one, which is we're not getting that information which said, look, this is an area of concern and this is how we're dealing with it.
So I think we'll take those comments on board. I think we're in the process of revising the report, as you know, and so we'll make sure that we look at the interim additional information that we can put in, as well as making sure that we incorporate those comments into the ongoing piece of work we're doing with the planning guys to do the revamp. So yeah, we'll have a look and make those adaptations. That's the word, isn't it?
I would find that extremely helpful. Thanks, Kath. Because we kind of left a little bit high and dry with this table in terms of knowing what's been done about things. My final query before we move on to other items in this section is the Triad system for patients who are unwell, which I'm very happy to note, and it looks very thorough and it's very detailed, and I'm very happy to note it. And I'm just wondering, do you see, I'm probably looking at Nicola for this, do you see any difference between frailty and being unwell? Because where some of this started was from a meeting that the chief exec and I and a couple of others and Stephen Harris had with a patient who was now very sadly passed some time ago, who was extremely frail. You may not necessarily have called him unwell, but he was very frail and needed particular looking after. He had some pressure sores and so on and so forth. So, Nicola, do you see any difference between frailty and unwell?
A really good question, and absolutely, they are two very different things. So what this really refers to is new score, which is somebody physically being unwell with with medical need, and frailty is very different. What I'd like to propose is I'll pick up some work with the head of nursing, Viv Cooper, to look at how we can do something similar, picking up frailty, and ask Tina Jenkins, our senior nurse for safeguarding and vulnerable adults, to work with her as well.
Thank you. That's fantastic response. That leaves me very, very reassured, because I know, Nicola, once you take something on, you take it on till it's done. Steve, I think you waved at me.
I just didn't want to lose Stephen Allen's point that he made about how we're developing the. Sorry, Donna, if you want to come back to it later. That's
no,
fine.
I will. You carry on.
Yeah, I just didn't want to lose it, and I think guidance will change, Stephen. I think fairly soon as we come out. I think we'll probably bring an update to the board in September via QS&P about how we might change as a result, and Nick might want to come in, which is probably closer to the discussions around almost a cornmeal transmission than I am.
Thanks, Yes, we do need to continue to revise what we're doing similarly with inpatient visiting, and I think we do need to pick up the conversation about volunteers and where we go with that going forward, because the risks are changing, and keep that agile. The other point, if I may, I was just going to raise was around capturing real-time patient feedback. Because that is at the crux of this, isn't it? It's the experience our patients are having whilst in the outpatients department. So really pleased to advise the board that today we go live in the inpatient ward with our new electronic real-time capture system using our iPads. So that's happening this week. What we will do is spread that out, albeit slowly, as we get the system up and running. But outpatients will be our second area of priority, and to start in real time capturing the feedback from patients en masse.
Thank you, Nicola. Steve, thank you for bringing that back to my attention. It was on my list, but I think I might have been about to miss it. So, Steve, I hope that answers your question, that we will look at how we reintroduce. It'll be brilliant to see the volunteers back.
Yeah.
They bring such a dimension, don't they, an atmosphere to the cancer centre. So, and in relation to 6.5, I think we've covered Appendix 1, Appendix 2. Does anybody want to raise? Yeah.
Jan did have a hand up.
Oh, Jan, sorry. Thank you, Steve. Jan.
I just didn't want us to forget that most of our patients have been shielding for a very long time, and how terrifying it is coming out of shielding. I spent some time with a patient last week who comes from a very rural part of Wales and came into Velindre to have treatment. And she was absolutely terrified of actually leaving the valley where she lived to come for treatment because of COVID, as well as the fear of the treatment. And what they did was they brought their caravan and parked it at Treadiga House caravan site, and she came in for treatment there from there every day. She was really impressed with the treatment she had, but also really impressed with the fact that she felt safe from COVID through the process. So although it is undoubtedly frightening sitting there on your own for half an hour with your mind churning over, the worst case scenario, it also afforded her some protection. So I do think we have to balance this, because after a year of shielding, it's emerging into a busy hospital environment would be absolutely terrifying for some patients.
Thank you, Jan. And one other thing to mention, because it would be, is nosocomial infections, particularly MRSA and some of the other C. diff and so on. Given what we've been through, the COVID pandemic, the vulnerability of our patients, our record for infection prevention still remains absolutely outstanding. And Nicola, perhaps you can, I'm sure the board would agree that we would want to thank our staff. That doesn't happen by accident. That happens because people work very hard at cross-infection processes and procedures and so on. And our rate is, for MRSA, I think we're about 7 or 8 years MRSA free now, and a very low incidence of some of the other infections. I find that incredible.
Just moving into 8 years for MRSA bacteremias, and I'm sure we will get to November of the 8 years.
Yeah, it's worth noting. Any other items in this section? Sarah, do you want to talk to the workforce dashboard?
Thank you, Chair. Yes, absolutely. We've already mentioned our current situation regarding staff isolating, but just point out that the current levels of sickness absence as of this week are 4.94% for a rolling year. And obviously that's tracking around the same now as we can see in the papers for May. So we're seeing sort of quite steady levels of absence, but we're keeping a very close eye on any hotspots within the organisation, as I said earlier. And that also goes for areas of PADR compliance. We are starting to see those numbers go up. especially in corporate areas where they've been low because activities sort of almost stopped due to the COVID response. We're working very proactively to ensure that those levels are now going back up. So very happy to take any questions, Chair.
Any questions for Sarah on the OD section of that report in that section? I can't see any hands up. Thank you, Sarah. And I think I might have inadvertently left out WBS. So Peter, I'm handing over to you if you want to draw anything to our attention on the WBS report.
So I think the main thing to mention from the WBS report would be the continued challenges of forecasting demand and making sure that our collections meet pace with that. So we did have a couple of cases where we've had to import red cells to make sure that we could meet demand, particularly over May bank holidays. I'm pleased to report that following that, we are now well advanced, as we've already mentioned, on recruiting an additional collection team that will give us more flexibility. We've also taken a hard look at our planning and forecasting processes because this one did catch us a little bit by surprise. So we've now put in place a monthly meeting which looks at the trends over a longer period of time than perhaps our daily review meetings are looking at, so that we can get a feeling for the directions of travel. And I suppose it should be reassuring to a level for the board to know that since we had to import back in May, in the last couple of weeks, we've actually been supporting other UK blood services because our stocks have been healthy and they've also found themselves in a similar situation. So I think the difficulties in projecting demand and planning for it are something that we're sharing across the UK, but actually the UK services are working very, very closely together to support each other. It is something that we just need to keep very, very close to as we come out of the pandemic situation and back into a business recovery and surge planning. Other than that, I don't think there's anything I would particularly draw attention to, but I'm quite happy to take questions if there are any others on points that are raised there.
Thanks, Peter. I can't see any hands raised. This is one example, isn't it, of being part of the United Kingdom. I'm not wanting to be political, but where we can transfer our product between countries when needs arise.
I think the mutual support agreement is truly a mutual agreement. We do all help each other out.
Yeah. Okay, so that concludes that 6.5. I propose that we now have a 15-minute break and come back at 11, just before 11:30, and we'll start with the finance report. Is that okay, Mark? Or 10 minutes. Oh.
Is somebody mute Donna?
Someone's trying to get hold of her to let her know she's not on mute. But we'll sort it, Martin.
Hello.
Hi. I only went to the loo, Steve. That's as far as I went.
I was too slow. So let me just check. I'm on mint. You're on it.
Oh, no, I'm not. I think, is everybody back? Hey, welcome back, everyone. Thank you for returning so promptly. And we now come to section 6.6 on the agenda, which is the financial report for the period to 31st of May 2021. And our Finance Director, Mark Osland, I invite you, Mark, to take us through these papers. Oh, there he is. I can see you there now, Mark. I couldn't see you.
Yeah, thanks, Chair. Yeah, the report that you've got presents the position at the end of May. If I could just mention, just in case there's any confusion, actually, when we discussed the QS&P highlight report earlier on, in that highlight report, it referred to the finance report being presented to the QS committee as being the end of June. That should have said actually the end of May. So it was the May report that went to the QS&P committee, and it's the May report we've got here today. Unfortunately, the June report just wasn't ready in time due to the timeline of issuing the papers. So I just wanted, in case there was any confusion. So coming back to the cover paper that you've got in front of you at the end of May, I'll just refer to some of the issues there as usual. 2.1, section 2.1, which is a table. It's the usual table. I've summarized the position, the bottom line position against our main budgets and targets. And as you can see, there's no major variances to report at this stage. This is the first detailed report to the board this year. And with a balanced financial plan having recently been submitted to government, you would probably expect at this point in the year, we are forecasting to achieve a balanced plan and a break-even position at the end of the year. But our forecast does, however, make certain assumptions, and I think the board will be familiar with a number of those assumptions, primarily that all our COVID costs are fully reimbursable by Welsh Government. We will receive all our planned additional income, and that our savings target is achieved. So the forecast is based on those assumptions. And also just to say to the board that all operational budgets have been formally issued to all directors and budget holders. And the forecast also depends on the expectation, as normal when we issue those budgets, the cost pressures that will surface, perhaps haven't been planned for, but they will be managed by budget holders to ensure that the delegated expenditure control limits that they've got are not exceeded. I've also mentioned in the cover paper that the Trust is currently planning to fully achieve its savings targets for this year. That was a risk. It still is an element of a risk, but perhaps that risk is reduced somewhat since the position at the end of May, because there was further work that we needed to do to get behind some of the details of those savings. And that has progressed. And at this point, again, there's nothing that suggests we should be reporting any major adverse variances. In terms of COVID expenditure, I have highlighted in table 2.3 of the cover paper the position. There's a substantial amount has either been received or confirmed, which is quite positive actually for this point in the year. And there's nothing to suggest that we won't receive the balance. But of course, there's no guarantee of that until we get final confirmation. And I'm not expecting really to get that until probably around September, October time, whilst further budget negotiations continue within Welsh Government itself at ministerial level to secure further budget for the Health and Social Services Group. Section 2.4 just briefly highlights reserves. We are keeping some reserves as we normally do, but as usual, I do emphasize that access to these reserves is actually on the basis that we are confident that all other financial expectations are delivered. And finally, just to mention our capital position, our capital budget, we have a confirmation of 7.3 allocation. That's in line with what we've expected, what we've asked for to date. So again, that's a positive position to receive that full confirmation at this point, which has of course allowed us to release all of our discretionary funding, we don't have to hold any of that back as a contingency as we have in previous years until we've had that final confirmation. So it's a positive position in terms of the budget certainty on our capital programs this year as well. And I think those are the main things, actually. I just want to say at this point to the board, to say it is early days. And we have had the June report off, but there is no major changes in any of those messages that I need to give to the board other than what I've just said. And I'll hand back to you, Chair, if there's any questions.
Thanks, Mark. Very good finance report to receive. I'm looking to see if there, oh yeah, I can see some hands. Martin? Katrina, Kate, was your hand up, or were you scratching your nose? Okay, Martin.
Thank you, Chair. Thanks, Mark. It's a very helpful report, a very clear report as usual. Firstly, an observation is you mentioned savings plans. And if I'm right in thinking, that was suspended last year by Welsh Government as a result of the sort of the pressure, the COVID-19 pressures, and sort of need to focus in on more on delivery and managing the pandemic. Clearly, that requirement to have a savings plan has been reinstated by Welsh Government. I'd just like to check that one. And the other question, which is the elephant in the room, is NHS pay. What's your current understanding of pay awards, and also the other half of that, of course, is what's your current understanding of funding of NHS pay awards?
On the savings question, Martin, just to say that the savings schemes weren't officially suspended by Welsh Government last year. What they did was actually support us with additional funding for those elements of the savings which we couldn't deliver. And there was an acknowledgement that we wouldn't be able to deliver all of our savings plans. And therefore that gap was actually filled by additional support by Welsh Government money. And it was about 50% actually of our target that we failed to achieve last year. And we did have that actually, as I say, provided to us from government.
Yeah, apologies for my poor use of language there. Thanks.
Yeah, in terms of the pay award, everybody will have seen the recent announcement, and there is a full expectation in our plan, and there is no information I have to the contrary that will be fully funded by Welsh Government, and we will receive that in due course, as we normally do through the budget process. So our plan is based on that assumption, and I think that's a fairly safe assumption to make, actually.
Thanks.
Thanks, Martin. Any other observations or queries for Mark? So, Mark, we receive and note the report, and in particular the financial performance to date and the year-end forecast, which is to receive financial break-even. Having said that, Mark, you won't be with us to see us break even at the end of the next financial year. So, colleagues, just most of you know that Mark is going to be retiring, and this is your last board meeting, I think, Mark.
Yes,
yes?
It is. Yeah.
It is, because you leave in September time before the next board meeting. So we will thank you as a board. I'm sure COVID restrictions will enable us to have some sort of event for both you and Jan. Well, hopefully we will. But I want to put on record the thanks of the whole board, as I'm sure Steve Ham will want to contribute to this, for the excellent way in which you've kept us safe and looked after the finances and so on, and resources of the trust over the last 7 years. And for me personally, Mark, since I've been appointed as chair, you've been enormous support to me. I can come to you with anything, and you give me a reasoned, careful, and you don't say anything when some of my questions might seem a bit ill-informed. You always look after me, and you're incredibly supportive. You're one of the nicest finance directors I've ever worked with in my entire 45-year career. And I think I can't give better praise to a finance director than that. But Mark, you're going to be missed. But on behalf of us all, you know, we wish you a very happy and long retirement with your son. As I understand, you could spend more time with him. And just before I move on, I just wondered, Steve, if you wanted to add a few words. You put a cup to your lips.
I did. I put it back down now. Yeah, I mean, I would actually, and I think Mark will hold on to that last bit about being the nicest finance director. It's not often in the job description.
No.
But it might be something we think about when we go through the value set for your successor. I'd just like to add my thanks, Mark. You've been an important part of the team since I picked up this role. And you forget how long ago that was, didn't you, in terms of how long you've been with us? And I think it's easy to take for granted getting to the points we get to every year with our financing. And it takes a lot of structure and organisation and a good team. And I know that you've developed the team as well over your period in the role. And for that, I really thank you. And you leave us in a good place, which is always a really sound legacy, I think, in terms of something to take away for your retirement and whatever you do next. And on a personal level, I'd like to add to Donna my thanks to you on a personal level for the support you've given me over the years. It's always important for somebody in my role to know which things they don't need to worry about, as well as the things they do. And you've allowed me that space, which has been really important. Thank you.
Can I just respond, Donna, very quickly? I just a few words. I'm not very good at this sort of thing, actually, because I get a bit emotional, because I will miss everybody. I mean, it's been a fantastic period in my career, actually, working in Velindre. I did come, it was 6 years, actually, Donna. I came here, I was on secondment for a year, and then I had this job full-time in July 2016, actually. Yeah, I've often said to people that this actual job, it's been the best job of my whole career. And I've been working for a lot of years now. And actually, I will remember everybody around the exec, everybody in Velindre's staff and my own team who have been fantastic in support. As Steve said, you know, I did change the team when I came in, and I've got a fantastic support network around me. And obviously that always helps in delivering your job. And I've said this quote before, and people, I'll just say it again, you know, you are only as good as the team that you've got, really, in doing your job. And they've been fantastic to me. But yeah, it's a very, very sort of sad and emotional time for me, actually, to leave. It's the right thing for me to do. I know that. I thought about it very, very deeply. But, you know, fantastic organization. Never, ever worked anywhere with such committed people, actually, that I work with here. We all know that how good Velindre is as an organization. And I just wish you all the very best in the future and all the success. There's loads of challenges you guys are still facing and will continue to face, no doubt, for a long, long time. And I'm sure you'll overcome them. And I'm sure the finances will remain safe. You say I won't care about it. I will keep a bit of an eye on it. I will look to see how things are progressing, and I will keep in touch with some of the staff and Sean as well. But just, you know, good luck to you all. Good luck to you all.
Thank you, Mark. It's a bit of a downer to get back to business now, isn't it? But that's what we have to do. But we will say goodbye to you again before you leave. There'll be plenty of time for goodbyes, Mark, before you go. So the next section on the agenda, section 6.70, which is the Trust Risk Register. So Lauren, I'm going to ask you to speak to this item.
Thank you, Chair. I just wanted to mention three things. So the last time that we spoke about this report still felt fairly theoretical a couple of months ago in terms of the developments that we've made on the framework and the ways in which we plan to get into the kind of real work of reviewing the risks on data across the organisation that are in the current version 12, and how we were then going to apply all of our new approach and and processes to migrating those risks into a new version 14. So hopefully the report shows the kind of the theory into practice transition of getting into the real work over the last few months on that. And many thanks to Peter, who's still here, and his team, and Lisa and Viv, and the VCC SLT. So it's a real team effort. The second point I wanted to mention was this paper has been to Audit Committee and QSP as well, and there was some great feedback on how we can, a couple of very minor things that we picked up on this version, but going forwards, how we can pick up some more divisional and departmental splits of the data to give a bit more granularity. And secondly, a bit more context as to why some of the data might look a bit different in different parts of the organisation to be more explicit in a report on that, which we'll pick up for next time. And so finally, to confirm for next reporting in September, there will be 2 papers. So there will be this paper with those amendments that I've just referred to. And then secondly, there'll be the risk register of all the risks that have been migrated into version 14 that meet the board risk appetite for board reporting. And that's what we're all working to at the moment. So happy to take any questions. Thank you, Chair.
Thank you, Lauren. Yeah, Nicola.
Not a question, just a bit of additional assurance to provide board members following discussion we had on this paper in the Quality, Safety and Performance Committee. Just note in the graph on page 5 that details target risk rating and 3 being aligned with target risk rating of 25 and 2 to a 20. So I just wanted to provide the board with some assurance that we're not targeting to have risks at the highest level of 25. That is indeed an anomaly, excuse my an inability to say that word, of Welsh Risk Pool's current risk rating score, and that is being worked on currently. So by the time it comes back to quality and safety in September, we will have what that actually translates into.
Thanks, Nicola. Stephen, Alan.
Thank you, Chair. Just wanted to say, and again, unfortunately, I wasn't at the Quality Safety Committee when this was discussed, so my question may already be covered. And Lauren, your second point about having another paper at the next board meeting may answer the question. Reading this as sort of cold as I am, it's very difficult for a member of the public to understand what it actually is saying, insofar as what risks you're talking about, because there's nothing to support actually to identify those risks within this paper. Because reading this as a member of the public, as I am today, it's very difficult to actually understand what those risks are and how you're dealing with them and what you're and how you're going to be managing that. Now, maybe in your second paper you mentioned coming up the next board. If that's the case, fine. I take that the assurance that will be coming out. But for this paper as it stands, it's very difficult for a member of the public to actually understand what you're saying.
Yeah. So, and it is a process. It's a transition paper in that respect. To Nicola's point, a lot of what is currently in version 12 is not fit for purpose in a number of fields, including target risk rating. So that's what we're going through with the divisional and corporate teams in terms of a review of everything that's there to ensure that that process will continue. So there'll continue to be this type of process paper, and then in addition, all the actual extracts of the risks that meet the board risk appetite as that second paper then in September, as you say. Thanks, Stephen.
I got Martin and then I think Gareth. Martin.
Thank you, Chair. And just to sort of echo some of the conversation we had at Audit Committee, clearly paragraph 4 says there are 800 and odd open risks in DATIX. That doesn't mean that the trust is currently juggling 815 risks right now. That's the information that's been put on the data, and part of the exercise is data cleansing. Yeah. Some of those have been open and not closed. Some of those should never been open in the first place. All those kind of issues. So really, it's the time it's going to take to clear those off, Lauren. So I just wonder if you've got a kind of a heads up in terms of timelines for when you're going to say, right, everything on this system is now accurate and we're only counting the things we should be counting, and therefore we can spend our time instead of worrying about what's on and what's on, they're actually worrying about what the risks are and what the mitigation has, to pick up Stephen's point.
Thanks, Martin. Yeah. Lauren?
Thank you, Martin. I don't want to commit to a month yet, but I will be able to very soon. I mean, Peter's smiling. We're discussing this a lot at the moment. So we can absolutely commit to the level that meets board reporting being migrated on, cleansed up and migrated on by September round of reporting, obviously ending in board on the 30th. In terms of everything that's currently in version 12, we're just working through the timelines then of those tranches. So I will confirm that in September, so that we've got that view of the complete picture.
I can see Gareth, you had your hand up, but Peter, do you want to respond to that particular issue?
If I may, Chair, and this is one of the the areas that Lauren and her team and my team are trying to pick our way through fairly carefully. What we've got to reconcile is the need to obviously give the board and the organisation assurance that risks are being appropriately identified and managed, and where possible mitigated, treated and closed out. But we also have, from a regulatory perspective at Welsh Blood, we have to provide very high quality evidence of the risk assessment process that goes into any decisions around changing, updating or improving our regulated processes. So many of the what are described as risks in DATIX 12 are actually our evidence that a robust risk assessment has been performed, and the risk that is recorded is a very, very low level risk in terms of scoring. So, maybe scoring 2, 3, 4, 5. But the question that Lauren and I are currently working through is it appropriate to close those risks, as they are low level risks that we are tolerating as an organisation? And the closed report is a report that provides the evidence that we did the assessment, or do we keep them open, which is what we're doing at present, so that we can also demonstrate that we're continuously reviewing those risks on a periodic basis. So it's really just to give reassurance that whilst there seems to be, for an organisation our size, a large number of items in our risk register, the reasoning for that is possibly that we're looking at this from two separate directions, and what Lauren and I are working through is how we square that circle so that we can provide evidence to regulators that we are assessing risks, and the risks that we're identifying are relatively low level, whilst at the same time demonstrating that where we identify higher level risks, they are recorded, mitigated, treated and appropriately reported. So I will share Lauren's reticence to commit to a date, but it's something that we are actively working on and we're putting quite a lot of energy into.
Thank you, Peter. I've got a query which arises from that bit of a discussion, but Gareth would have had his hand up first. I can't jump the queue just because I'm chair. And then Steve, you will have to leave shortly, Steve. You're on mute.
I was just going to say I need to leave and I'll rejoin as soon as I can.
Yeah, okay, thank you.
Thank you, Chair. And my question was along a similar vein in relation to those open risks, really, recognising all the comments that have been made. And I was just wondering whether we are able to, and knowing that comparators are dangerous, but what number of risks should we have on our open risks on a risk register for an organisation of our size and complexity of operations? And I know that might be an impossible question to answer, but nevertheless, I will ask it.
Yeah, it's a good question, and it relates to another conversation we're having, because to kind of go around it a little bit, I will come back to the actual point. Obviously, the risk appetite levels that we set as a board last September then correspond to the level of reporting here at board in terms of risk score. So when we start seeing that in September, it'll be the first time that we'll actually see the reality of how that risk appetite has translated in that way. Because what we then may want to do as a board is to think about the levels of risk appetite that we potentially now have, having seen whether that needs to be amended, seeing it in practice. And actually it should come together timing wise, because then in November we'll be due for our annual review of our risk appetite levels. So so I think that's one way which we can practically work through the answer to that. The other point your questions prompted, which I haven't done yet, and I will do, is in terms of kind of I've looked at the other organisations' risk registers for certain things, not actually in terms of pure number. So I'll do a bit of a benchmarking exercise, and we've got a peer meeting tomorrow actually of my peer group, so I'll pick it up then, just and get some information on that for us as well.
Thank you.
Thank you. So the query that I have, and it's not that I'm being impatient, but I appreciate the hard, detailed work, Lauren, that you, Peter, and others are doing to get us to this place, and it'll be worth the wait and worth the pain when we get there. I'm absolutely certain of that. In the meantime, are there risks, that we are not addressing or dealing with as a board because we don't have in front of us a populated risk register? Should we have any concerns at this point?
I think from an assurance on, so it's clearly a fair question and point. In terms of the assurance that we can take, so at the year-end board meeting on the 8th of June, we had a view of the most significant risks that we thought there were to the organisation, which form part of the annual report. Mm-hmm. And they didn't have the detail of the scoring or the kind of controls and actions as we will do going forwards. But that was a view from the exec team, which we then had both at audit committee and board in June. So we do have a very recent check that there wasn't anything through that process for year-end reporting that actually isn't covered through other governance channels. So whether that's through the divisional reporting through QSP or specific agenda items that we may have on CANISC, for instance. So we do have a recent check. Your overall point is,
I know that, for example, we will have updates on the things that are our difficult issues, which would include CANISC, for example, and that's being reported. Yeah. I thought it needed to be asked as a question, because if we don't get a populated risk register in September, and don't take that as a criticism, I just want to be assured that we're not letting things slip. So I'd want to see, perhaps in the next, if it isn't a populated risk register at September's board, and as I said, I'm not saying that as a criticism, I'd like to have something of a report about some of the an update on some of the key risks, and whether our mitigating actions are increasing or lowering the risk, or whether things have got worse or better, whatever the appropriate language is. I think that would be, and if we do a bit of a stock take, I think some of our key risks we are getting updates on anyway.
Yeah, exactly.
Elsewhere in the agenda, so they don't appear in the agenda item risk report, but they appear elsewhere in the agenda.
Yes.
Yeah. Okay, that's really helpful. Hilary.
Yeah, thank you, Jem. Maybe going back to the discussion around whether the risk is closed or not. From my perspective, a risk is a risk. It might be a low score risk. It's only not a risk and should be closed if it's no longer a risk, if that makes sense. So maybe you consider that when you're looking at what remains a risk. In my mind, it doesn't matter whether you've got 800 risks, as long as they're being managed, and it's the scoring, it's the outcome of the highest risks that they're being reported appropriately is in my mind, most important.
Thanks, Hilary. Lauren, do you want to respond to that?
No, just agree, and I can see Peter nodding as well.
Yeah, of course we agree with that, Hilary. So thank you for the report and the discussion and the observations. We're asked to note the content of that report, noting that the work has resumed to implement a new risk process, note the closure of risks is being monitored, and that follow-up reports will be presented to the board. And if, as we've just said, we're not in a position to have a populated risk register in September, we will get updates elsewhere on the agenda about any issues that will be concerning us. And I'm sure Canis will still be on that list. So that now takes us to item 7 on section 7, strategic development. And the first item here is the highlight report from the last meeting, which I think was on the 10th of June, which I'm handing over to Stephen Harris to present. Stephen.
As you say, this is the highlight report for our last meeting on the 10th of June 2021, and as I'll come on to, also includes one item which relates to an extraordinary meeting we held on the 28th of June 21, which it will be the last item I come to as I go through the report. So as always, I presume people have read the highlight report, but I will pick out certain elements of it just to draw the board's attention. So there are no items that I need to escalate or the board of. In the advice section, there are 7 of them. I'll just pick a few of those out. So we received an update on the ongoing development of the acute oncology service. There's a business case in preparation. Clinical colleagues in the trust are working with clinical colleagues in Nairon Bevan, Cwmtarf and Cardiff and Vale Health Board to develop a more integrated service across the region. That work is ongoing at the moment. The perceived benefits of it are described there. So the committee received an update from management and clinical colleagues on progress in finalising that business case. I'll skip down then to the Welsh Blood Service and a business case to update the infrastructure there. This is the headquarters at Llantrisant, and we've been advised that we've been awarded £150,000 as a trust to support improvements to the physical infrastructure at the building itself, and also to help support us towards an aspiration of having the site as 0% carbon dioxide, in other words, carbon dioxide neutral. And if we were to achieve that, obviously that'd be a huge achievement for the trust. And in parallel with that, there is ongoing support around general modernisation and upgrading of the site. And in particular to note that it's now been classified as an NHS Wales critical facility. I would have presumed it already fell in that category, but apparently not, but is now being so classified. The next one is the digital health and care record update. We received a verbal update from Stuart, who happens coincidentally to be attending the board today, on the replacement. We referred to Canis several times already, our clinical outpatient information system. We're having to replace that. We had a verbal update on progress towards the September 2021 deadline, which marches ever closer. Clearly, there's a very significant piece of work, a lot of risks associated with it. We received a verbal update from Stuart, and we've asked for a formal detailed paper to come to our next meeting. And then lastly, in this section, the other section, I've just skipped down to estates. So as the board is aware, relatively recently, we've taken over legal responsibility, ownership of the proposed site of the new Velindre Cancer Centre, just north of Whitchurch Hospital, the field there. That previously been owned by Cardiff and Vale Health Board. That site is now transferred legally to the trust. And with that comes, of course, all of these statutory and legal obligations that will be associated with any land or property owning. And of course, I appreciate that there are challenges, etc., to the use of that site, but that doesn't remove some fundamental legal and statutory obligations we have, in particular around health and safety. So we've received an update around some work which will have to be undertaken to ensure that the site is safe for people to access and for people to use, enjoy as they do at the moment. and that will include the removal, for example, of some obstructions and debris and returning the site to its natural state, and of course a recognition that there are objections to the use of the site, and this action may, of course, cause some negative reaction in the community, which of course we actually understand. But this is very much around ensuring we comply with our obligations from a health and safety perspective. And then as things move forward, as things develop on the site, there may be areas of the site we actually need to fence off to ensure that safety is maintained, but that is further down the line. In terms of inform, several headings there. I'll just pick out a couple of highlights. We had an update on patient engagement, the partnership board update, plasma for fractionation, and I'll skip down the last one where I need to introduce a correction to the wording. I mentioned we met on the 28th of June 21, an extraordinary meeting. There was a single item of business, which was the annual operating plan, the IMTP as it's called, and that was considered and endorsed a submission for approval by the board. And because of the timing of it, that approval actually took place under urgent chair's action. Now, this highlight report concludes by saying that the detail of the urgent chair's action is included under agenda item 3.2 of this trust board meeting. That's not correct, that the cycle of business being what it is. So that will be received by this trust board at the next, as part of the next update of chair's urgent action, which whatever the cycle of business is. So I need to amend that final sentence to say that it will be included. I've got the exact wording here, included in the next reporting of chair's urgent action matters reported to the trust board. So I'll pause at that point, Chair. I'm happy to take any questions. I'm conscious, of course, both Steve Ham and Carl are not with us. So depending if there are questions which might need Steve's input, we may have to come back to them, but I'll happily try and deal with any questions or comments.
Thank you, Stephen. Just to note that Steve Ham has been called to a very important meeting in Welsh Government, and he will be back later. So if we can't answer any of those questions now, we will get the answers to you as quickly as we can. So are there any observations or queries for Stephen on the highlight report of the Strategic Development Committee? No, that's a committee that was a bit of a slow burn, Stephen, but now is, got quite a full agenda as well. As it's developed.
It's sort of in QSP has a very large number of items, and by comparison, strategy planning, etc., has a lesser number, but it does afford us the time, of course, to go in to these things in a lot more appropriate detail and really start digging into some of the big strategic issues and challenges facing the trust. So it has taken a little bit of time to get going, but I'm very happy with it, and that we are afforded the time we need to give these things proper consideration.
That would square with my observations too, Stephen. Thank you. So the next item we come to 7.2, Transforming Cancer Services Programme Scrutiny Subcommittee. This again is over to you, Stephen.
Thank you, Kate. So a shorter highlight report here, just summarising the last meeting, which was the 20th of July 2021. Under advise, we received the most recent finance report, and as you can see highlighted there, the position at that particular time, I'm not sure if it was end of June, I think it was end of June rather than end of May, was that there's a small underspend of £3,000 on the capital budgets and a small overspend of £13,000 on the revenue budgets, and actions are in place to ensure that a balanced year-end position will be delivered by the year-end, which will be for this March 2022. Under Assure, we received an update on the risk register, and again, as highlighted here, obviously the risk register now reflecting the fact that a judicial review has been launched and there's a process to be gone through, and we'll have to await the outcome of that particular process. And then under Inform, we received a communication and engagement update, which I don't plan to go into here because it's entirely covered off in the next Trust Board paper, which Norm, I presume, will be presenting, item 7.3. So again, Chair, if there are comments or questions, I'm very happy to try and deal with them.
Thank you, Stephen. Are there any queries or comments for Stephen on this highlight report? I can't see any, so just one last look in case. Lauren, you just lit up. No,
Sorry,
I think it's just.
I was getting ready for the next one.
Okay, so we note the contents of the report and the actions that are being taken. Thank you, Stephen. 7.3 is Transforming Cancer Services Communication and Engagement Update. So, Lauren, you're leading this, is that right?
Yes, thank you.
Thank you.
So I just wanted to pull out a few pieces from the report. One sentence in the background, section 2. So in terms of the strategy and our approach, emphasise the importance of good one-to-one stakeholder engagement, building positive relationships and informing our patients, staff and communities of interest. And it's something that we've said for a long time, but actually going back well over a year now, some of the approach that we were taking was fairly broad brush and impersonal, with the benefit of hindsight, to some of the ways in which we were updating through the website, for instance, as one of our key channels. So I think hopefully the report provides the assurance to the board that actually that approach is now being borne out in everything that we do. So just to cover a few items, in terms of communications, we've touched on judicial review and media coverage is summarised. I also just wanted to highlight the importance of the digital conversation that's been launched during this period through our Velindre Matters social channels. And that's the work that's supported by Down to Earth project. And it received some great media coverage, which is outlined there. The results of all that engagement will be fed through and available for the next reporting period. And the other piece on comms is the second Velindre Matters newsletter. Hopefully you've had a chance to look at it. If you don't, to give it another bit of a plug, there are some great sections in there, including 5 minutes with Paul Wilkins, not to be missed, as a video. And as we started in the first version, there's a You've Asked, We Say section. The volume of queries that we're getting from the community and other stakeholders is still fairly hefty. And that's an important way in which, rather than feeding back individually, we can summarise those key themes on a regular basis to explain. So that newsletter is going out, as we've talked about before, to a really substantial distribution list directly of our key external stakeholders, as well as available through our Velindre Matters channels. Then in terms of engagement, we've touched on the Radiotherapy Satellite Centre engagement a couple of times in these reports, and that's now concluded in this reporting period. And Fran in my team and Andrew Haig have worked relentlessly on ensuring that was a success. We've had, as well as the actual events, direct events, we've had 275 responses to the digital survey, which is fantastic. And again, the result of all that work will be summarised back through in the next reporting period. So sort of two pieces to expect there for September. And again, we've also referenced in the meeting, but the work on the patient engagement steering group, which many thanks to Hilary for chairing, and Kath and Non continue to lead a really amazing approach for the organisation in that respect. Then the Minecraft competition, the winners have been going through the finals of selection and communication, and we look forward to being able to share more on that very soon. And the community events, just finish where I started in terms of the importance of that one-to-one actual face-to-face now engagement with people who really care and are interested in what we're doing, is continuing to progress at pace. So there's been 4 community events with different parts of the neighbourhood around the site over the last 6 weeks, and that activity is very well supported by our MS and MP, and that programme is set to continue as well. Thank you, Chair.
Thank you, Lauren. It's been a very busy time for our comms team, as you might imagine, and I don't think there's going to be any let up in that anytime soon. They're working very hard, and I just want to put on record my thanks to them for that. And I'll take, well, Lauren will take, and I will chair any questions or observations for Lauren. Martin.
Thanks, Chair. Thanks, Lauren. I think this is really helpful to understand all the engagement work that's been done. I just ask a little bit around the bullet that talks about the Velindre Matters social channels. Velindre Matters exists as a standalone Twitter feed, I think that's the word. It doesn't have an awful lot of followers thus far, and obviously we need to sort of boost that by sort of retweeting it through even the Velindre fundraising and the Velindre University Trust and the Cancer Centre Twitter feeds that we have. There's a risk of having too many, means it's hard to keep track of them all. I just wonder what other social channels we have. Do we have an Instagram account? Do we have Facebook? What are the social channels we're using to get our messages out?
Yes, so for Velindre Matters, as you say, there's the Twitter feed and there's a Facebook page. So they're the 2 for now. I know we are, well, we haven't talked about it for some time. In terms of the other channels, it's correlates then to manpower to manage. But it has been some time since we've talked about Insta, and I'm not going to try and name the ones that young people actually use these days, as opposed to the ones that
TikTok's next.
referring to at the moment, probably. Yeah, the kind of new list. So it hasn't been a conversation we've had for a little while. So it's a good. Thank you for the question. I'll pick that with Non. I think it's worth formally kind of just going back around that. We'll include that in the next report, just our conclusions.
Thanks.
Thanks, Martin. There are other Facebook pages which are not anything that Velindre hosts, and they comment, which I know the team keep an eye on, and they read what's going on there, and if there are any issues. That often feeds into the you said, we say, or into a specific post in Velindre Matters. So we don't ever address directly, because it's not our Facebook page, but where appropriate, we'll feed it into either a post. What you don't call them video clips anymore. What do you call it when a podcast, is it? I don't know what's the technical term. I really don't know. But we'll put something through Velindre Matters, which will be addressing the concerns that have been raised. So there's that as well. I can't see any other hands up. So thank you, Lauren, for the approach, and we note the approach and the themes of work that are described. We'll have a little bit of a break with meeting the politicians because we are in recess, but but we're still in touch with them, and that will start up again as we come toward the end of next month. The next month is starting in 2 days, so that's not a long time away. Okay. The next agenda item that I've got is item 7.4. Now it says here that we're supposed to start lunch, and lunch was due to start at 12:40. And the last time earlier in the agenda, we were like this, and we had quite a bit of time. And I took another agenda item, and we took quite a long time to work through it. But colleagues, if you're happy, I'll take 7.5 and then see how we go with 7.6 in terms of timing. Is that all right with you, Sarah?
Yes, that's fine, Chair. Absolutely.
So can I hand over to you for item 7.5?
Absolutely. So 7.5 is our detailed explanation of our new approach to dealing with equality, diversity and inclusion through our executive team ambassadors and workforce and OD ambassadors. So hopefully colleagues have had a chance to read the paper, and I just wanted to pick out a few key points. So this paper really outlines the active measures that we intend to take as an organisation to challenge discrimination, and most importantly, to achieve a shared ownership of the equality, diversity and inclusion agenda at all levels of the organisation. So whilst I hold the executive lead for this area of work, we feel it's very, very important for all of our executive team colleagues to be involved and actually to be driving these themes through their particular portfolios. So basically what we've done is we have, to ensure that we have this agenda better integrated, we've identified the exec team equality ambassadors, and you can see on the bottom of page 2 and beginning of page 3, the exec team equality ambassadors per area of work under the ED&I agenda, and they very often align with the protected characteristics and go beyond that to actually look at the broader aspects of the work that we want to promote within the organisation. We've then got the workforce and OD team members who are equally aligned with these areas of work. What we can then see on page 3 at the bottom of that page is what we have then put in place to support those individuals, recognising that this may be quite a leap for some colleagues really into areas that they've not explored previously. And I have to say that through my engagement with this training and engagement aspect, colleagues have embraced these opportunities wholeheartedly and have really taken on board the different areas that they can now start to get involved in. So just like to commend colleagues for that really and that enthusiasm. What we're also recognising that whilst we've aligned people to particular areas of the ED&I agenda, we can't ignore that these things overlap. And it's very, very important to consider the intersectionality when we look at our specific areas of work. And that's something that obviously we've been talking to colleagues about in quite a lot of detail. What we're then providing colleagues with are opportunities to, for example, attend trust staff networks. And we have a number of staff networks, but certainly not as many as we might like. Many of these have grown during the pandemic as colleagues have felt that where they belong to certain groups, that they want to come together and share difficulties they may be experiencing. So those networks have grown, and actually having allies attending the networks can make a huge difference. And I think that we've seen that borne out through the pandemic, but also beyond that, really to consider the more wider aspects that we need to be dealing with. We're also inviting colleagues to attend the monthly equality impact assessment meetings, and not so much attend meetings, but really see the work that flows through those conversations, where we are looking at our strategic work and our decision making and our policy making from all of the angles that we actually look at through the equality lens, if you like, take that lens and approach things a little bit differently. And we know historically that we've benefited from that in the past. This is providing those exec team members now with the opportunity to see that work in more detail. What we've then got, you can see a little bit further down, is asking the ambassadors to think about how these areas could be better represented in their area of work at the strategic and operational level. And hopefully this will start to flow through the work we do as a wider organisation. So this is the start of that, I would say. We've then got, very importantly, and today is the first example of this, I'm really, really pleased that we've got to this stage. We will be presenting at every board an ambassador showcase. Today we have started with race, and Jazz has been nominated to be first in line, as it were, to present the ambassador showcase. This really is an opportunity to, at exec management board and at board in the same month, actually present their views on our current situations, but then from an ambassador lens, think about what we might want to do and invoke a conversation about how we might take these agenda forward. So this is a very important opportunity for us now at every board meeting to consider different elements of this work rather than see ED&I as a whole, if you like, where we can lose some of the nuances, I think, that actually are impactful on different people from different protected characteristics. So that's my sort of overview. Hopefully I've picked up the key points of importance there. We're very happy to take comments or questions, Chair.
Thank you, Sarah, and thank you again for the thought, the thinking that's gone into producing this this paper and the developments that it represents. So I'm going to open that up to questions or observations for Sarah. Martin.
Thank you, Chair. Thank you, Sarah. I think it's a very helpful paper to understand how we're progressing on this. And you flagged the ambassador area previously. One point of nuance which you brought out in the introduction of the paper, but isn't actually in the paper, is you talked about the areas that we allocate the ambassadors go beyond the Equality Act, and I think you quite rightly have said that gender identity is slightly different to what's actually in the Act itself, so that's helpful to understand. It's kind of appropriate that we're having this conversation today, because today, in fact, Welsh Government have launched their LGBTQ plus action plan and consultation. Obviously, we'll need to feed into that. Just one comment generally, I guess, that as when Jan leaves us in September, I think I'm going to be taking over the EDI role as a board sort of champion. And so I'll be really grateful to be involved in any of those ambassador conversations, just to make sure the board is cited on some of those things as well. A quick question on the ED&I pledge, that's the bottom page 5. Are those 6 bullets the actual pledge itself? I couldn't quite understand that. And is that a pledge that we as a trust have made, or is that what's the origins of that pledge document that's at the bottom of page 5?
Thank you for the points, Martin. Yeah, to come back in terms of involvement, absolutely will involve the independent member ambassador or champion in terms of this agenda in our work going forward, a commitment to that. The pledge here, maybe the word pledge makes it sound more formal than it actually is. But what we've done is make that commitment really as an organisation. So that isn't a formal external pledge. That list of bullet points is our ambition really in terms of how we want to move this work forward.
I wonder whether we as a board should absolutely sign up to that. I mean, it's really helpful and sort of very, very obvious. I think perhaps we should, but okay, that's helpful to understand the context of it. And a last small point, I raised this with you previously, Sarah, the little graphic on page 6 in the middle there, again, doesn't represent the actual Equality Act categories, but it's an interpretation of them. And again, it also flags lots of organisations we're involved in, and it includes Stonewall Diversity Champions, which I gather we are not a member of. So again, that just needs to be updated for accuracy.
Thank you, Martin.
I found just that last bit a bit difficult to hear, Martin, but I think I've got the gist of it. Sarah, you and I talked a bit about this yesterday, and we agreed. And Martin, you and I have had discussions that I think as a board, as the IM members of the board, there's a lot for us to be sure that we're on board with, we understand, that we're contemporary with. So we will discuss now as this work moves forward in all the ways as described in the paper, that there needs to be some board development sessions, which we'll discuss about what the best ways to take those forward. It's interestingly and surprisingly in some ways, it is now a fast-moving scenario, all of this, and you can very easily slip a bit behind, can't you? Particularly if it's not an area that you think you're dealing with day in, day out, you can slip behind. So we will put together a development program over a period of months, Sarah, won't we, to make sure that IMs and any other board members, I'm sure, that we're that we're developing in the appropriate way, which aligns with how the agenda is going forward.
Absolutely, Jen. I think. Sorry, Janet, if I may come back. You're absolutely right. This is a very fast-moving area of work now, and I think, as we've indicated in our ambition, really, we are now moving beyond the Act, if you like, to actually look at what sits below and around that. because it's okay to define protected characteristics, but it's that much, much broader emphasis and impact that we know we need to have on, for us, our staff, our patients, our donors, and the wider community. So yeah, it's very interesting to see Welsh Government direction of travel now in terms of these specific action plans, which is what we moved away from about 10 years ago. We started to look at it as a whole, but I'm very pleased to see now that we are recognising the differences that different groups actually experience. So I think it's an interesting journey for us as a board, as an organisation, to grab hold of that. Thank you.
Thank you, Sarah. I think I saw Jan's hand up. Yeah.
I can't stress enough that language is really important in all of this, and having a common language and a confidence to be able to discuss these issues, because the world is paved with good intentions around this, but it has to be about outcomes, and we won't get the outcomes unless we all feel confident about talking it. So I think those development sessions will allow us to develop a common language, because the language is changing all of the time, and it's massively contentious. You know, yesterday there was stuff in the press about pronouns on email signatures. There's always going to be a backlash. This can become a divisive issue unless we actually, I think, keep our eye on the outcomes. But we do need the confidence to know we can all get it wrong in the language. We're there to be helped and supported to make sure that we can have a full and frank discussion.
Jan, I couldn't agree more. I think you might have been listening in to our conversation that Sarah and I had last night. I want a safe place where I can learn and develop, and that's what I'm looking for, to give me that confidence and competence to fulfil my role as a chair and as a citizen of this country. Okay. Now it's 12:34. We ought to be breaking for lunch at 12:40. I've had a suggestion from Lauren, which I think is an excellent one, that as we're going through through the agenda, that we start part B at 2 o'clock, which I would be very happy to do, because it will mean we'll finish the day earlier. I'm wondering, Jazz, you're leading the next item. Shall we have that item and then we'll move to integrated governance?
I would suggest it follows the conversation we've just had.
Exactly,
so
exactly.
Just complete it. Sarah is actually going to kick it off. It's a double act. So some slides are coming up, and Sarah will start.
Thank you both.
Absolutely, thank you. The opportunity to work with Jazz on this. And as I've just said, in terms of the paper around the executive team equality ambassadors, today we have our first ambassador showcase, which is on the subject of race. And I just wanted to place us in a little bit of context with this. So if we can just move to the next slide, just to really help us understand what's happening. And we've sort of alluded to this in the previous conversation, that Welsh Government have recently closed a consultation, it happened on the 15th of July, on their new race equality action plan, with the ambition that we become an anti-racist Wales, and that sort of flows through and is the aim of that action plan. We did reply to the consultation as an organisation, and I'd just like to thank colleagues for their comments and contributions to that reply. Very importantly, this action plan addresses a number of areas which go across the public sector. And what you can see here on this first slide are the 13 policy themes, which then have underneath them goals, actions, and outcomes. So this consultation, as I said, have just closed with the anticipation that the action plan will be launched in September. That's the latest date we have, but also with the aim that we will hit the ground running once that launch has taken place. So we'll talk a little bit more about that in a moment. If we can move to the next slide, what we can see here is that one of the goals under the health, the health theme, if you like, is leadership and accountability. And you can also see here that this really challenges us as an organisation. It challenges us in terms of being anti-racist, as opposed to being non-racist, and Jazz will say a little bit more about this later. It also challenges us to use different language in this area. And it's interesting, we just had this comment, didn't we, on the previous discussion around language and the fact that language moves on and changes, and challenges us not to use BAME anymore as an acronym, and actually that Black, Asian and minority ethnic people as a whole, or minority ethnic in terms of shortening that. And I think we need to rise to that challenge in terms of moving our use of that language on. Also, very importantly, that this action plan was pulled together from with a steering group that had a huge number of contributions, both within its actual makeup, but also as subgroups underneath. And I was very lucky to be part of one of those subgroups, particularly looking at the health area of the action plan. So it's going to have a huge amount of credibility with stakeholders, and it's incumbent on us obviously then to rise to the challenge in terms of enacting the action plan when the final version is published. That steering group will now become an accountability group to actually deliver the action plan. And that accountability group will hold Welsh Government itself, but public service and others to account. And that accountability group will also then procure nationally the anti-racism training for boards of public bodies. That's something for us to particularly be aware of in terms of where that leads for us. And it's said that that will happen within 12 months of the enaction of the publication rather of the action plan. Just picking up a few other points then, just under the leadership theme, just to begin with. One of the areas of work here is to take steps to make senior leaders in the public sector more personally accountable for improving representation and making public bodies anti-racist. So that is all senior leaders across our organisation, and that each of those people will have clear performance expectations and appropriate incentives and sanctions. So that's a very different place for us to be in. And we'll have to think that through very carefully as a board and as an organisation. And as part of that, they will implement the diversity and inclusion strategy for public boards and require each chief executive, chair and board member to have performance indicators which properly reflect the importance of improving race equality outcomes. And this is back to the outcomes which Jan mentioned previously. So that is going to put all of us in a very different place. And I think to pick up your point, Chair, about training, education, information, that is going to really be our responsibility to ensure that we have that. And we will definitely be making sure that we have that as we need to. One of the other actions into health is that Welsh Government will introduce a workforce race equality standard, or the RES. This has been in place in England for quite some time, where they also have a medical staff workforce race equality standard. So it has a number of components. And at the moment, we're having conversations in Wales about the RES, if you like, and what it should actually compose of, rather than do a lift and shift from England, where actually there's been some reflection on the ability of the RES as it stands to actually tell us what the outcome differences have been. So it's okay measuring things and reporting against them, but actually do they tell us the difference that these actions have actually made? So in Wales, what we're doing really is deciding on what we want to change and then working backwards to determine the measures that we should put in place to ensure that that is clear. So I think we're taking a little bit of a different approach, and I've been really welcome to be part of that discussion nationally, just to make sure that that sits in the right place, which I think is going to be a hugely important vehicle for us to measure the difference. So that's just an overview really of the action plan, and obviously we will have a huge amount of work to do now as an organisation to get us to a place where we can respond appropriately. But beyond that, to say what is our ambition as an organisation in this area of work. So at that point, I will hand over to our exec lead ambassador for race. I'll hand over to Jazz.
Thank you, Sarah. Next slide, please. And whilst that's happening, just on the actual agenda, I've been described as the executive medial director. And maybe that was appropriate, because this is about, in a sense, getting to the middle. So for this presentation, what does that mean? So just recapping on what Sarah has already said in the cover paper, that we are, as a trust, taking active measures. We're challenging discrimination. We want to develop this shared ownership of the equality, diversity, and inclusion agenda. And it's about all levels of the organization. It's not a conversation just for board today. And so it's how we as the executive team and members of the workforce and OD team are aligning ourselves. And in a sense, we're doing this under the umbrella of the Equality Act 2010. We gave this presentation on Monday at EMB, and interestingly, the ripples from that, some personal feedback that I've received, and the fact that Lisa, who may not be on the call now, was really keen that the SLT in VCC should do something similar. And that's, I suppose, exactly what we want to see, is this kind of engagement, people getting excited about this agenda and joining forces. So next slide, please. Let's just look at our current trust sort of profile in this area. I mean, we are active, and there's quite a lot that we can say that we are involved in, and that's largely thanks to Kerry, who is on the call. I'm anticipating, and she is the person behind the scenes who's clearly been driving this agenda and helping us so far. And some examples on the slide. Black History Month, we held numerous events, from screenings of how Black nurses saved the NHS to talks from historians Abu Bakr al-Shabazz on Black history in medicine and health. We've been involved in the annual Minority Ethnic Communities Health Fair. We have the More Equal Wales initiative, increasing the access for people of all backgrounds to blood and transplant donation. Many of you in this room participated in the Stephen Lawrence Day and the Windrush Project. I do encourage you, if you haven't tapped into that and listened to the videos, really powerful memories of people working in the NHS, and interviewed by members of our staff, including Kerry, including Joe Oshen, a new consultant.
Can I just ask about the Windrush Voices? I found that incredibly powerful, and it represents an archive of a period of time. And I'm just wondering, is it going to go anywhere? It sits with us. Is it going anywhere else?
It's probably Kerry to come in and answer that question. I can't see you all at the minute.
I'm not sure if Kerry is on the call, Jazz,
right,
but that this was shared across NHS Wales, Donna. And that's where it went as it stands at the moment. But I think your point is well made in terms of sharing this more widely than that.
Yeah, I think it needs to go wider than the NHS. It represents for me a fantastic archive, that we've captured, because some of these people, they're not going to be around forever, and we've captured the story, which I think is extremely important, and would encourage you, Sarah, through your networks, to see if we can't get that out to a wider circulation.
Absolutely, Chair.
Thank you, Chair. Also, one other initiative I do want to mention, which is not on the slide, is the ESOL project that Velindre has been leading in collaboration with Public Health Wales and the Cardiff and Vale College, and they recently won an award for Black and minority ethnic health awareness. So we have got Dr. Seema Arif, who has been leading this work. So this is a project which started around English speakers of other language, around improving English. And what they did was to bring in an element of health awareness into the project. And they've tackled topics such as screening, health prevention, donation, blood donation. And there's about 240 students a year. It's been running for 5 years, so that's about 1,200 or so students that have been involved in this project. So it's a powerful example of how one thing can lead to another, but using one vehicle as a tool to tackle a number of areas. So next slide comes to a kind of more personal point about what this role means for me. the first thing to say is I'm not an expert, and I was slightly hesitant taking this on. But the first important thing is really this concept of being anti-racist versus non-racist. And so it's about not simply saying, well, I don't hold racist views and leaving it at that, but really being active to change the situation. Being active so that you become part of the solution to the problem. The second point I just wanted to raise was about the box ticking. So does it matter which box I tick? I've worked in Velindre for 25 years. I think most people know that I come from Malaysia originally, but I wonder how many of you on this call actually know what race I am. So I am by race a Sri Lankan Tamil. Now, does that matter? Well, it matters. If we talk about language, then I can speak a bit of Tamil. I grew up in Malaysia, so I actually did my whole curriculum in Malay in a different language up to GCSE, and then I came to the UK. So it influences the food I cook. It influences my national dress, should I have a formal event to wear one, which hasn't happened of late. So I do think it is important because it does define a part of who I am. And yet many people are choosing not to tick the box. They're choosing to leave it blank. And I think that's something that we need to understand. So for me in this role, it is about knowing who is out there and making this meaningful connection. And through the pandemic, things have happened, haven't they? And I think we are looking at things differently, perhaps, in terms of the race agenda. So through the pandemic, I was invited to come and speak to the BAME network, or Black and Minority Ethnic, as we should be referring to it now. And it was a wonderful opportunity to make a connection with people in the trust and across our hosted organizations to talk about where people came from and what the issues were with through the pandemic. And many people, like myself, have not been able to see their family. So I haven't seen my mother for 2 years. I probably won't see her this year, might be next year if I'm lucky. And I think it is helpful to understand those challenges for our minority ethnic staff. There's a huge opportunity for me in my role, and I'm privileged to be able to influence perhaps on a national agenda, so around the medical directors table, using other levers such as the GMC, the colleges, King's Fund, to really seize the opportunity to make a difference. And the next slide I'm showing you is one that is positioning Dame Claire Marks, who's the chair of the General Medical Council and somebody that I hold in sort of huge regard, high regard and esteem. But some of the messages here that Dame Claire Marks is saying, we all deserve the same opportunities, the same timely, honest feedback, the same encouragement or constructive critique. But the GMC's data clearly shows disproportionate fitness to practice referrals of ethnic minority doctors and unequal outcomes in education and training. And she says this is not simply chance alone. So it's time to address this. And therefore, there are two goals that have been now, a commitment has been made that we should eliminate this disproportionate fitness to practice by 2026 and eliminate the unfairness in medical education and training by 2031. And similar conversations and statements are being considered by other groups. I know the Nursing and Midwifery Council are also looking at this and also have been making very strong statements around this, as have been other professional and non-clinical groups. So it's something that is happening, and it's happening now. So I just have one more slide, you'll be pleased to know, which is about what the role means for the trust. Now, this is very much more about the what rather than the how. partly because we just haven't had the opportunity to get into the next phase. But using the goals that Sarah has just presented to us, then there's around leadership and accountability. How do we, involve people of minority ethnic groups to take leadership roles, and also demonstrate zero tolerance of discrimination as a trust. Now, we have examples of leadership in Wales. I should mention that this year, Sue Tranker has been employed as the new Chief Nursing Officer for Wales, and she's also the first Black and minority ethnic Chief Nursing Officer in the UK. And I guess you've got me. So I'm told that I'm the first female minority ethnic medical director in Wales. I might be proven wrong if you know anyone else that's had that role. But it's now about how we take this leadership to widen the access, but then also understand what the challenges are for our patients, our donors, our staff, and identify the things that we want to achieve. With the workforce, it is about promoting our staff engagement. I mean, we have the network, but not all members of our staff participate in it. And that is work that we need to do there. And it's about giving them the voice to achieve this inclusive environment that we want to get to, because we don't really know what the issues are right now. And that's something we need to understand. Data and intelligence will be absolutely key. But what we do know at the moment is that people are choosing to leave the boxes blank. And we are therefore not confident about our numbers. So just a simple question about the proportion of our workforce that might be within this category. And when we talk about access, there's lots that we need to consider. I think for the service, if we look at cancer, then there's prevention, screening, service, and research, entry into trials. Do we know what that access is like across different groups? And for blood and bone marrow donation, increasing the access is absolutely key, particularly with the whole bone marrow story, where we do have a problem which we need to address. So the health inequalities, I mean, the pandemic has exposed this gap more than in a most powerful way, hasn't it? And it's in a positive way, it's helped to profile the race agenda, but the story has been quite unpalatable at times.
Yeah.
The deaths from COVID, the poor outcomes, and some of the socioeconomic divide. And the use of the risk assessment tool, I mean, that was really helpful to start conversations, but some people found that very difficult because there was, again, it was pointing out a difference, which might have been perceived as being negative. So we have got a huge agenda in front of us. We will need to distill this, and we've talked about a board development, perhaps to take it to that next level, to get underneath the detail of the how and the what we will actually do. We've talked about outcomes. So what are the outcomes we're going to target and what that will look like? I haven't got that full presentation for you today, but it is about hopefully raising the awareness and doing that first start of the journey, demonstrating a commitment, and then considering, and I'm going to hand over to Sarah about what the next steps might look like. Thank you.
Thank you, Jazz. Should we conclude with you, Sarah, and then open it up?
Absolutely. Thank you, Jazz. So
okay.
This is just a slide really outlining what we may do now in terms of next steps. And we've mentioned a number of these things throughout our conversation today. So we're very, very keen, obviously, to continue to work with our Black and minority ethnic staff network, which is now called Unity at Velindre, and how we hear their voice and really listen and take account of what they say. We need to determine what our ambition is, and I've used the word ambition a number of times. So what is our ambition as an organisation? It isn't simply to meet the requirements of the action plan. What is it that we actually want to achieve in terms of making a difference to people? And we absolutely want to engage the board on specific board member responsibilities. We know we need that training, we need that support, we need that education. And of course, determine what our specific gaps are so that we do meet the requirements of the action plan. So that's really the start of this conversation. So just really happy to take questions and comments. I believe Kerry has now joined us, Chair.
Oh, hi, Kerry. Thanks. if we can have the, yeah, okay, I can see, oh, my thing just fell off. I can see everybody again now. I've got, apart from endorsing the direction of travel and everything that we're doing 100%, I sent an email earlier this week to the charity team and the fundraising team, because what can we make sure we involve the charity in all of this work? You know, I had a paper this week suggesting names for additional ambassadors, and they're you know, no problem with the names put forward because of the incredible work they've done to date for the charity. But I've asked the charity to have a look at our list of patrons and ambassadors, and are we, you know, what's the diversity look like there? You know, when we're funding all kind, you know, what we decide to fund and how we decide to fund it. So please include the charity in all of this work. Is that that's a yes, Sarah? Yeah.
Sorry, yes, absolutely, Chair. I'm writing down furiously. Thank you.
Thanks, David.
Yes, thanks, Chair. Just on that point as well, Sarah, does it just solely look at the workforce, or are patients like ourselves, the patient liaison group, volunteers, will it include that wider audience?
Absolutely, it's around service users, patients, donors, and staff. So this agenda actually is that whole, covers that whole remit.
Right, yeah. Fantastic, thanks.
Martin.
The other subgroup in this, of course, is board members. And of course, I noticed in one of the slides earlier, our erstwhile colleague, Judge Ray Singh, formerly of this parish, is featured heavily in this work at the moment. I learned a lot on this topic from sitting next to him in the days when we used to be able to sit side by side in this area. Yeah. I know, Donna, that the gift of recruitment as board members doesn't sit within us. It's a Welsh Government Act, but a plea, as I know we did last time, is we try to get that advert, get awareness out across the board to ensure that we get a wide range of applicants from all different sectors of society. Just to make sure we have a rounded board that represents our patients, our staff, our donors.
Yes, thank you, Martin. It's a tough one, and I would welcome any support or help. I know Kerry helped me the last time we appointed board members. Kerry Harris helped me. We reached out to the RNIB. We reached out to various race equality groups. We really tried our very best to contact all sorts of groups, and we did end up with 2 expressions of interest from individuals who wouldn't be eligible to join our board because they worked elsewhere in the NHS or they were advisors to ministers in Welsh Government. So anyway, but we will, yes, Martin, you make a good point, and we have to address it, but I would welcome whatever support colleagues can give me to ensure that we're reaching out. However, in our last board round, as I said to Sarah yesterday, we were able to recruit 2 Cymraeg-speaking independent members, which I'm also extremely pleased about. I mean, this is such a broad agenda, isn't it? It's a very broad agenda. Kath, I can see a hand up, so I'll go to you next.
Thanks, Chair. So just to let you know that we really will be incorporating this whole agenda into our service change. So as part of the Velindre Futures, one of the aspects that we will be considering is the whole diversity and inclusion, and also to let you know that that's a key theme of the work that we're doing around the patient engagement framework as well.
Thanks, Kath. Jazz, that was a really interesting presentation, and thank you for sharing some of your personal insights with us. Now, I think I'll carry on with the agenda. It will probably take us till 1:30, and then we can have a half-hour break before. I know you have to leave us, Stephen, shortly, don't you? But if we carry on, would colleagues be happy with that? We'll finish probably about 1:30, and we can have a half-hour break before part B. I can see people nodding, so I'm going to do that. So the next item is 8.10, which are the Audit Committee highlight reports for 2 meetings. So I'm going to hand over to you, Martin, for that item.
Thank you, Chair. We always save the best till last, don't we?
Yeah.
I try not to take more than an hour on these 2 papers. Okay. The first meeting is the extraordinary audit committee meeting on the 8th of June, which is scheduled expressly to approve the accounts. It was, if you recall, the morning of our last board meeting, and those two things went hand in glove for the approval of the accounts. Everything ran swimmingly in terms of the accounts, and again, as we've heard, all the tributes to Mark and his team in terms of getting the accounts through. I'd like to be associated with the comments that you and Steve made to Mark previously about the work that he and his team have done, and he will be missed. An excellent set of accounts delivered, again, entirely whilst the staff are working remotely, and with all the wildly exceptional activities being done around COVID, particularly across the shared services partnership, with the volumes of activity that flowed through there, where they were managing all of the NHS Wales contracting for PPE, and the extraordinary numbers of spending that flowed through there. So the one speed bumper you can see highlighted in the paper, and the advice section halfway down the paper talks about the opinion the Audit Wales gave on our accounts, and you can see in there that the committee registered is disquiet about the communications around that, and there will be lessons to be learned, to put it mildly. And that's really, it was a single item meeting, and the board has previously signed off the accounts and all the documents that were agreed there. So happy to take questions on that one before I move on.
Any queries for Martin?
Okay.
There are no hands up. Martin, do you want to move to the second item?
So the second audit committee was a regular audit committee meeting, which was held on the 8th of July. And it was quite interesting that this was the first audit committee that's been held in the post-NWIS world. NWIS transferred as a digital city health authority on the 1st of April. So that freed up some room in our audit committee, which could easily taken up with lots of other activities, however. As you can see, there are quite a number of the things that are on here have come across the board's agenda anyway. I mentioned a few things. We talked about the standing model standing orders and the standing financial instructions. We've already received those this morning. We've also received the report on risks, which is into the assure section. A couple of things to just tease out, if I may. One of the general assurance areas that the board and the trust as a whole relies upon is an assurance framework. Work is developing heavily in that area, and as you can see, we had an update from Lauren at the July meeting, and you can see the note there. It says the framework is going to go to the MB in August and then come to this meeting in September. Another area which the audit committee has spent some time on in the last couple of meetings is around private patient debts and ensuring that debts which are properly due to the trust are properly chased, because every bad debt in that area is money which potentially is lost to NHS patients and for their NHS treatment. So we're keeping a very close eye on that area to make sure that the work is to chase those is properly stepped up, I think is a safe phrase to use, to make sure we don't lose any more money than we absolutely have to. Moving on to the assure section, we haven't actually had anything from Kate from Audit Wales today, but I'll mention the structured assessment phase 1 report on operational planning. And I think, as it says here, it's a very positive report, and there actually weren't any recommendations arising from that. But I think it's probably been circulated to members to see. It's a very positive piece of work. But there's a phase 2 piece of work which is going to happen now. I think it's going to be reported back to us in the spring. I see Kate nodding. Excellent. That's the main areas of activity. There are other normal business of the organisation which are flagged to inform, which I don't intend to go into in any great detail. You can see a long list of audit reports there on page 3, all of which receive either reasonable or substantial assurance ratings, which are effectively well above the line in terms of assurance. Happy to take questions.
Thank you, Martin. Picking up on the private patients' debts, could you keep that on your highlight report agenda? Because obviously that'll come back to you at the next audit committee meeting, and I think it would be helpful to have a report following that on your highlight report to the next meeting of this board.
Absolutely. As you can see, some independent work is being commissioned, and the audit committee will be receiving that, and it'll come back to the board.
Thank you. I'm looking to see if there are any other hands up. No, so we note those reports, Martin, and thank you very much. I've got one item of other business that I would like to raise. Is I am not sure, Donald, whether this will be your last meeting or not, but it could be your last but one, or it could be your last one. I'm not sure, because we're trying to, Donald's work commitment, particularly during COVID, when it was hugely increased, and it was quite difficult. And he's had long conversations with Lauren and I about how best to manage that, and we've decided in the end that he needs to concentrate on his clinical and other responsibilities at Cardiff and Vale, but said that he would stay with us until there is a replacement. And we have submitted a name to the minister, and we're waiting for confirmation that that name has been approved. And until then, Donald is working with us. But even though you've been very busy since COVID started, the input that you have made to the work of this board, Donald, has been excellent, and we've been very grateful for it. And some of the interest you took in research work in the trust as well. So I don't know if this will be your last meeting, Donald, but if it is, I'm saying goodbye and good luck and thank you. What did who wrote the Hitchhiker's Guide? I've forgotten his name.
Douglas Adams.
Douglas Adams. He said goodbye, so long, and thanks for all the fish. I was going to say, but this may not be your last meeting. We'll just have to. Our colleagues, corporate colleagues, Emma is pressing the Public Appointments Committee to get this name approved as soon as possible. So we are working on that. I've not been made aware that anybody else has any other items. So the date and time of the next meeting is the 30th of September from 10 till 2:30. Thank you, everybody. And what I suggest now is that for those of us who are staying to part B, I noticed Stephen has, from Community Health Council, has left us. He said he would be. We'll recommence